I'd just like to apologise that we're obviously having this meeting today on the 13th of January, when our scheduled meeting should have been on the 6th of January. But just to explain is that what we decided to do is that due to the significant pressures on the hospital and the community services, there was a lot going on just over the Christmas period. So we agreed to postpone the meeting for a week just to ease a little bit of pressure in terms of our senior colleagues preparing board papers. So apologies for any inconvenience there in that situation. Before we start the meeting proper, it's my pleasure to formally welcome Jo Behan to her first meeting of the Rotherham Foundation Trust Board. Jo is our recently appointed Medical Director, and we're really pleased to have you with us, Jo, and look forward to working with you going forward. Welcome. In terms of apologies for absence, due to the change of date, it's been a bit unfortunate that our Chief Executive, Richard Jenkins, hasn't been able to make this particular day due to a very important previous engagement. So Michael Wright, our Deputy Chief Executive, will be standing in for him today. And unfortunately, Angela Wenziki is also not able to be with us today as well. So we record her apologies. Are there any other apologies, please, Dawn?
Not that I'm aware of, Chair.
That's lovely, thank you. Coming back to our agenda then, we are quorate, and in regard to declarations of conflicts of interest, I think we need to record Steve Ned, your regular conflict as a joint executive director of workforce at both Barnsley Hospital and here at the Rotherham NHS Foundation Trust. So we'll know that. We'll now just ask is, having read the board papers, has anybody identified any potential conflict of interest? No, thank you. Well, again, the normal format is if during the meeting you actually feel that there is a potential conflict, then raise it at that particular point. Thank you. So can we now come on to the minutes of our previous meeting, which was held on the 4th of November 2022. And first of all, are they a correct record? Are you comfortable to sign those off as a proper record of that meeting? All agreed? Thank you very much. Are there any matters arising that you identify from the minutes that we don't have on the action log or the agenda? Anyone wants to raise anything? Right. Thank you. On that basis then, let's come on to the action log, which is the next item on the agenda.
Sorry, Martin. Sorry, Martin, to interrupt. I did have my hand up there.
Sorry, I can't see it, and if it's still up, I still can't see it. I'm sorry.
It is still up, yeah.
Is it? Right. Okay, just bear with me. Right. My apologies, Heather. I can't see it.
It's fine. My apologies if this is actually in the papers. If it is, I have missed it. But in response to Richard's report last time, Steve confirmed that we had contingency planning for all the strikes, and with everything that's going on, I just wondered if we could have a quick update on the contingency planning for the trust, if it isn't included anywhere else. I've missed it if it has.
Well, let's say, in a sense, that's actually some additional information, I think, Heather. So if you'd be agreeable, perhaps, Steve, you can pick that up, an appropriate report, possibly on the operational report item there. Can we do that?
I'm happy to do so.
So we'll not miss that, Heather. It's a good point that we need to identify. So thank you for sharing that. Coming back now to the action log, you have that in front of you. You can see that we've got a number proposed to be closed and a number for open. Has anybody got any comments on the action log? Or are we comfortable to agree the status as presented? All agreed? Oh, sorry, Heather, I can see you on.
Sorry, on item 18, which is an issue, and obviously apologies if this was discussed at quality, because I unfortunately wasn't able to go. It talks about the new reporting framework for the quality committee, and the The answer to the response on that, where we were missing quite a few metrics that allowed us to track the objectives, it just says that we'll do this in due course, which, you know, is very vague, and it was quite a pressing priority for this year. So I wondered if we could have a commitment to when that would actually be achieved.
Yes, thank you, Heather. I got that as a point on my notes, so thank you for raising it. I think, Helen, you're our lead on the Quality Committee. Could you just give us a response to that, please, Helen?
Yes, certainly. So I've been working with Louise, who is producing the IPR, and looking at the best way of doing this. What we're doing, because of the pressures that we've got within her team for producing data, is looking at starting a new format with the new quality priorities that commence in April of this year. So we are just looking at making sure that we're working through the quality priorities at the moment, but the new format will commence from April 2023, and then it's in place for the whole of the new financial year going forward, rather than changing it at this late stage in Q4.
All right, thank you for that. Okay, Heather, that's the information. Thanks very much. So we'll now move on to the report of the chairman. That's a written report that's presented in the papers. I'd just like to highlight the first item of the report around the escalation from the Council of Governors. And just to pause and just to mention really what the process really is. And this is a demonstration of the actual governance working in action. So when we have a public meeting of the Council of Governors, they obviously are able to look at all the documentation as presented and reports from the board. And it's also their prerogative to raise any issues that they may have some concerns about. And it was pleasing to note at the Council of Governors, the public meeting, is that our governors were generally concerned about the welfare of our employees, of our staff, and really wanted some assurances around a series of points. So there's a separate item on the agenda where colleagues will respond to that escalation. But other than that, any questions on the report, or just happy to note it? Thank you. Let's now move on to the report of our Chief Executive. And in the absence of Richard Jenkins, Michael is going to pick up this particular item. Could you just highlight anything in particular, Michael, you want the board to be specifically aware of in addition to the written report?
Yes, thank you. Just the increase in acuity and the pressures that we're facing our urgent emergency care department. The fantastic staff survey response rate, which is just under 61%, the results are embargoed, but that does put us as one of the higher end within our sector. And finally, what's not in there, our colleague Louise Tuckett, our Director of Strategy and Planning, has been offered a secondment on a part-time basis with the Department of Health and Social Care, focusing particularly on elective care. This starts from now. Louise will be with us still, but on a part-time basis, spending 2 days per week approximately with the Department of Health. I think it's a great opportunity for the Trust to have a look at what's happening in elective care nationally, and also a great opportunity for Louise. And that's it. Thank you, Chair. Happy to take any questions on the report. Smashing.
Thank you. Well, just to say, Louise, on behalf of the board, is, congratulations really of being given this opportunity. So I hope it'll be good for your development. And but as Michael says, I'm sure that will be good for the Trust as well, in regard to having some insight and participation in what it is that's going on. And hopefully, we should be able to identify some good practice as well that we may be able to learn from. So thank you very much indeed for that. Cameron, please.
Sorry, just thanks, Chair. Thank you. Just looking at the operation planning guidelines that were attached to the report. As I read through it, there were a number of things obviously resonated, and I could see, where they're being picked up either through reports or meetings. But there were some that didn't resonate, and I suppose that raised the question of what is the process to make sure that every substantial point in there we have consciously addressed. So I guess I'm looking for assurance that we have considered everything that's in there, and we've either consciously decided to do it, partially do it, or not do it. So what is the process to achieve that?
Thank you for that question, Cameron. Michael, please.
Yes, absolutely. So in terms of our operational objectives, which we're currently developing, the guidance within the planning is being considered. A lot of the targets are must-dos, so they'll be factored in and they'll be featured on our IPR. As part of our planning paper that we have on the agenda for later on this morning, we do call out some of the key deliverables there. So it will be captured in some of the other work that we're doing as well.
Thank you. Heather?
Yeah, it's on a similar theme actually, picking up on Cameron's. The planning guidance, you know, they're all laudable objectives in themselves, but I think there's a bit of a theme that you don't see anything to do with the outcomes expected for patients. It's all process orientated, so it may be implicit in there, but when we develop our own objectives by hitting the targets that we set, what do we think that will do to improve the outcome for patients? Yes, they might get seen faster, but you know, if we look at the international league tables, we languish quite low down in quite a lot of the outcomes for patients. So, you know, the whole point of a process should be for an improvement, and I'd like us to pick that up within our planning objectives this year.
Yeah, I think that's a fair point, and really that's what we should be doing, isn't it? In terms of our operational plan, we should be focusing on the outcomes, not just the actions and the processes. So we'll pick that point up, Heather, and ensure that that's actually part of our development activity to get to that stage. Thank you. Anything else on the Chief Executive's report? Before I move off this report, I just wonder, Louise, if I come back to you now. Now we've reported about your secondment, would it probably be useful if we just make a note in the minutes of a possible declaration of interest as a result of your sort of short-term secondment, because of the obvious various discussions we'll have with regard to elective care and elective programs. Louise?
Yes, I think that's absolutely appropriate, Martin. Just to note, I have recorded that both at the Department of Health and Social Care, my role here, and on my staff profile as well. So I have done that declaration, but I think you're right, it should be recorded and noted here formally. Smashing.
Thanks very much indeed for that. Right. So all done on the report of our Chief Executive. We'll now move on to an item on our agenda, which is always a pleasant one and an interesting one. So we have a staff story for presentation today. If I could come to you, Steve Ned, our Director of Workforce, who will introduce this story. Steve.
Thank you, Chair. As you say, we have a regular feature at the board, the public board meeting, which alternates between a patient story and a staff story. And this month is a staff story, which hopefully completes a loop that we started some time ago in terms of our staff story, because those board members who've been here a while will remember we heard from a colleague who's part of our supported intern programme. And what we're doing today is kind of completing the loop by sharing the successful completion of a journey on the supported interns programme for Oliver. So first of all, I'd like to welcome Emily, Oliver and Laura to the meeting. Welcome to the public board meeting, and hopefully we're not too intimidating for you, and grateful for you joining us and sharing your story. So Emily, I don't know if I'm coming to you first or Laura, but I'll come to you, Emily, if you can just set the scene in terms of what we're doing, the context in which we're doing it around our role as an anchor institute and the work that we're doing with the college and with supported interns. Thank you.
Thanks, Steve. So for about the last year now, we've been working with Wayfinder, which is part of Landmark Specialist College, to provide supported internships for young people aged between 16 and 25 who have an education and healthcare plan, which you might have heard referred to as an EHCP. So they're young people generally with a learning disability or autism. The idea of a supported internship, it's a form of extended work experience with additional support in place that's designed to move people towards being ready for employment. And Oliver came to us some time ago as a supported intern, He and his manager Laura are going to talk about how he's settling in as an employee now within the trust. As Steve mentioned, supported internships form part of our role as an anchor institution within our local community, providing employment opportunities for people who often experience significant health inequalities. And we know that good work is one of the best ways to tackle health inequalities. So I'll hand over to Laura and to Oliver now.
Hello, thank you, Emily. Can you all hear me okay? Brilliant, fantastic. So thank you for having us. Oliver's been with us since October, after he finished his supported internship with the help of Emily. She was looking for roles that were available throughout the trust that would be suitable for Oliver, and approached me as we've got a 20-hour clerical officer post on a band 2 out to advert. As Emily has just said, looking at sort of health inequalities and the way in which it's very, very difficult for individuals with learning difficulties and autism to be able to get into employment, especially through a formal interview process. So that was one of the first things that we did that was slightly different. It was a much more informal. Oliver came in with your tutor from the college, didn't you? And we met informally in my office, had a good chat, talked about the different experiences that he'd had and the different skill sets that he'd got. So yeah, he started with us in October on a 6-month fixed term contract. And it's going from strength to strength. He's doing really well. He's fitting in to the team really well. And from my point of view, it's just been a slightly different way of thinking. You can get exactly the same out of individuals, but it's thinking about the better way to address the training. So we've done sort of step-by-step training instructions, checklists for the individual tasks so that Oliver can go through and tick off the individual bits that he needs to do. He didn't need to use them for very long, I will be honest. He's picked things up very, very quickly and is a bit more of an IT expert than me. This whole Zoom was very nerve-wracking for me. But Oliver picks up all the different IT things absolutely fantastically. And then we've done daily checklists as well, haven't we? Yeah. So we've tried to get a structure in place for every day of all the different things that he needs to do within the department. And we've got all that written down so that when he comes in at 9 o'clock, he knows exactly first job, sorting out our blood cultures and preparing those for our phlebotomist that has been able to get them concentrating on the ward and taking that pressure away from them, haven't you? He does work for our photo-free cyst department, getting patient care plans together, posting patient information out for our anticoagulation nurses, as well as helping us with our new electronic booking system called Bookwise that we're utilising outpatients. So yeah, there's lots that we've trained you on, and there's a little bit more training to come as well. But from my point of view, it's been a very rewarding experience, but really, really good getting Oliver in, and you've been a real credit to the team. So thank you.
Thanks, Laura. Chair, are you happy to open it up to any questions or comments?
Yes, thank you. Thank you very much, Laura, for your contribution, and welcome to you and Oliver. And it's very good to hear Oliver is progressing within the trust, so that's good, and well done, Oliver, and long may that continue. Obviously, a very interesting story. Anybody got any comments you'd like to make? So I've got Cameron and then Sally. Cameron?
Thanks, Martin. Hi, Oliver. Yeah, congratulations. There were mentions of sort of some procedures or ways of working that have been adapted to, basically set you up to succeed. Is there anything else now in retrospect that you think could have been added to that list? Anything else that we could learn from your personal experience?
You think there's anything we could have done that was different?
No, not really. It's been a really good experience so far, and I've been able to settle in really well and get. I've been able to get my work done in time, and yeah, it's been a good experience so far.
That's good to hear. Thank you, Sally, and then Zlaka.
Thank you, and thank you both, and Emily as well for that. My question were a little bit more around what we can learn from the process that we might be able to roll out in terms of wider recruitment. So you described making adjustments in terms of that interview process, and it can be a tricky process to navigate. Is there anything you think we can roll out more widely, Laura, in particular, but Oliver as well, in terms of what other managers might learn?
Yeah, because it has been a learning curve. Obviously, it's the first time I've done anything like this, and it was very different not doing a formal interview process. But I think, and I know there's been a lot of talk recently in meetings that I've been in, that just because somebody's not good in an interview does not mean that they aren't capable of doing the job. And it's thinking of different ways to which we can approach that. And how we can do more informal interviews, or I know there's been some talk of people having the interview questions beforehand so that they can prepare, and it's sort of thinking outside of the box really with that. And certainly I'd be happy to be involved with anybody that was taking on a supported internship person going forward. Because, yeah, I can share the experiences that we've had and the learning curves that we've had as well, with the different training materials that we've utilised. But certainly it's important to get to know your staff member and offer that support and just work through what's the best way for them. I did actually forget a couple of bits actually when I was talking. We did have some support from Landmarks College. They came with you for the first 2 weeks every day, didn't they? Yeah. So helping Oliver navigate the transport system, getting on the buses, getting to work, and then helping him settle in with us. And then also we've got a staff member with an outpatients, which is sadly left to move to a different outpatients, but he is also autistic and has acted as a mentor for Oliver, and he's still doing that even though he's moved to a different area, just so that Oliver had got that support if he needed it as well, which I think has been helpful and just comforting that side of it. So
thank you. It's absolutely how we get the best out of people, isn't it? Thanks for that.
Yeah.
Thank you, Louise, please.
Thank you, Martin. I was sitting here thinking that this doesn't need to be said, but I actually think it does. I think when you hear stories like this, you know, the real value comes from people like Laura investing the time and effort into this, because it's optional to many people, isn't it? It's something people think, well, I can do that, but it's more work, so I might not. And Laura has done the same thing with when we launched the Kickstart programme. Laura put her hand up and said, I'm going to support. And actually, she supported an individual with some real challenges and invested a huge amount of her personal time in that. And I just think I was thinking it doesn't need to be said, but I really think it does, to recognise the amount of effort that goes into this from the manager. And I just wanted to then say a big thank you to Laura, because I think you're a role model in that regard and a credit to the organisation. And like I said, others think this is optional, but it isn't, it shouldn't be. And I think you show that and you demonstrate that in the way you work. So you absolutely embody our values, and thank you.
Thank you, Louise. That means a lot. Thank you.
Thank you. Well said, Louise. Well said. Zlaka?
Yeah, Sally asked my initial question, but my other thoughts now are that we need to look at how we can plan this into our objectives and look at other areas or other roles that this sort of work could be developed. So as part of our equalities development, it should become part and parcel of our organisational work.
Yes, thank you. That's a good point, Zlaka. Yeah, I'm sure that will have been noted. Thank you. Right, colleagues, well, thank you very much for your comments. Laura, thank you for what it is that you've done to obviously enhance this opportunity that Oliver has obviously seized. And it's been good to hear that you're settling in well, Oliver, and we hope you'll have a good career within the NHS. Thank you, Emily, for bringing the story to us. Thank you.
Thank you, everybody.
Thanks, guys.
Thank you. Bye-bye. Moving back to our agenda now, we've got our Freedom to Speak Up quarterly report, and very pleased to welcome Tony Bennett, our lead Freedom to Speak Up guardian. Helen Dobson is our lead executive for Speak Up programme. Is there anything you'd like to say in introduction before we allow Tony just to highlight any key items from the report he's prepared?
Thank you. Yeah, it's just to highlight that this is the Q2 report. So because of the way board meetings fall, it is a slightly delayed report coming to this board. So there is some movement since this report, but we can cover that in the report. And there is quite a detailed appendix as part of this around the stroke unit, which I will probably come back in on after Tony's delivered the main report, but I'll hand over to Tony initially.
Morning, everyone. Thank you, Ellen. Thank you, Chair. Just to pick up on the key points of this month's report and look back at the Q1 report as well. As Louise raised some questions on that last report. We've had 7 concerns raised in Q2, which is a slight reduction in Q2 last year. So I'm quite interested to see what comes back on the staff survey results this year. What I would like them to have shown is that staff feel comfortable raising the concerns with the line managers, and as a trust we're moving towards that as a culture, which is brilliant if that's the case. If it's not, then it means that we need to do more work in promoting freedom to speak up in Q4 and onwards. But that'll be something that we'll be able to pick up once we see the staff survey results. Of the 7 concerns that were raised in Q2, we had a further 2 raised from the stroke unit. Regarding patient safety and the culture within the department. Helen will be able to pick up on that in the appendix once I've finished. I have spoken to the staff since then who raised the concerns in both Q1 and Q2. And the work that Cindy and Helen have been doing is greatly appreciated by the teams. And they're starting to see a change on there. So I think Helen will pick up on that when she talks about it. But it's, from my point of view, it's really pleasing to see that it is starting to change, and we have to start somewhere. But everything they're saying is it's going in the right directions, and they want to be part of in creating enhanced patient safety in that department and changing the culture. So really good from my perspective on that. Our masked figures are excellent, as they always are in relation to freedom to speak up. I expect them to drop off a little bit in Q3 and Q4 due to the fact that we're launching it as a 3-yearly refresher. We're pretty much one of the first trusts in the North East and Humber region to do that. And it makes sure that we comply with all the National Guardian's Office guidance in relation to speaking up. So again, that's a great step forward for us. Just to go back into Q1's report, there was some data published by the National Guardian's Office regarding types of speaking up data. Unfortunately, that was just the headline figures in Q1. We did hope to have the full report published in Q2. However, that got delayed slightly due to the fact of the Prime Minister's being up for re-election. So that report has gone back to Parliament this week. So hopefully we'll have that published in Q3/Q4, so we can report on that on our next board report, so that you can see the headline national figures and we can compare them to our local data, which again should be able to give us some areas that we need to work on as a trust. Any questions in relation to that?
Thank you, Tony. Yeah, again, another good report. Thank you. As you mentioned, I think Appendix 1 is one that we really need to get some assurance on. And as it actually happened, the actual chief nurse's walkabout yesterday took in the stroke unit. So I and 3 of our governors had an opportunity to speak with colleagues on the stroke unit, obviously listening to what the changes were. So when I read this, I did confirm that this was historical in a sense. It was obviously earlier in the year and some progress has been made. But any other comments before I come to Helen about the stroke unit? No? Thank you. Okay, Helen, if you would pick that item up, please.
Yeah, thank you. So because it was, we'd had those concerns raised over a couple of months from a number of colleagues that had come through Tony, We initially spoke to the division, and the division had put some plans in place, but we felt it needed a bit more corporate oversight. So the Jodie, as our Director of Operations, along with Cindy as Deputy Chief Nurse, with support from HR, set up a series of listening events so that we were able to meet with a range of people in different settings. We made different offers to the team so that just so that they could feel comfortable speaking up about what their concerns were. The themes that came out are covered within the appendix, and they were broad reaching, but I think there was a big thing around team working, communication, and how they could work. And I'm sure it didn't help that they were working in a quite difficult physical environment as well. So an action plan was completed. It was very comprehensive. It had 38 different points, but at the request of the division, we did hand it back to the division for them to oversee the implementation of that. They've been making good progress through that. It took a while to get going, but it has now. Most of those actions, we've only got one red action, and that is out of their control because we've still got some external decisions to make about the neuro rehabilitation service, which is causing a bit of unrest on the department. But 20 of the actions complete, 17 of them still in progress. I think the key thing now is that we keep having those touch points with staff and checking that they do feel that it's making a difference. And I think yesterday with our visit down there, and that's what we're doing, is regular walkabouts in the team. But when we see them and we see how the team are working together with the therapy teams and the nursing teams and the medical teams all pulling together, having those sort of like board rounds, where they all come together to plan the care first thing in the morning, it is making a difference. They're in a nice new environment, and that is helping. The main thing for us now is to just keep embedding this and make sure it doesn't slip back, and that's what we'll keep doing. So I think it's been a positive outcome, but we just need to make sure for future learning that we probably get in there a little bit quicker so that things don't escalate as much as this one did, and that we can resolve matters more promptly. Apologies, I think you're muted, Martin.
Thank you, Helen. We've got a number of colleagues who would like to make a contribution. So Dee, Nicola, and then Joe, please. Dee?
So first of all, I think we need to recognise that it's out in the open, which is a really, really good thing, that actually this is cultural change. So really welcome, Helen, that embedding. We as a board need to recognise that culture changes over a period of time, and we might see some little blips on the journey. And I think that my final point is around the national benchmarking. Because it will be still really difficult to gauge where you are on a national basis, because the culture in organisations, the size of organisations, the structures of organisations will be different, and we should focus on the themes that come out from that rather than where we are, I think, in a benchmark. That's me done, Martin. Thank you.
Thanks very much. Nicola?
Yes, thank you. Just wanted to go back to your point, Helen, about the learning around it took a while for this to get going. And I just wonder, in terms of specifically, what could we have done differently to have addressed this sooner? What's the key change from your perspective?
I think it's about the ownership of the problem, and it was initially the division were quite keen to deal with this themselves, and I think they did put measures in place, but as concerns were still being raised, we did not feel as a corporate team that was a sufficient response, and so we felt we need to intervene. And I think that next time I need to ensure that from a central team that we are intervening quicker, just to make sure that any local response that's been put in place is sufficient for what is needed.
Thank you.
Thank you. Joe?
Martins, and apologies for being slightly late. I was just going to mention that when we received this paper, People Committee, it was a week after we'd had the conversation of the paper we're seeing later on the board around reciprocal mentoring, and we kind of felt that there's a sort of connection to be made between the Freedom to Speak Up Guardians and making sure that we're surfacing earlier some of the sorts of issues that we're hearing through the reciprocal mentoring exercise. And so I think that's one thing that's being taken away as an action to look at how we recruit a more diverse group and increase diversity within the Guardians.
Thank you for that,
and
Joe.
I think that has been picked up on, and we're acting on that.
Smashing. Do you have any comment on Dee's point about benchmarking and about different size stroke units? Anything you would like to add to that?
I think the thing with the benchmarking nationally, we hear they say we should be very cautious with benchmarking. And the thing with freedom to speak up information is that it is primarily it's about what's happening internally within your organisation. So although it is interesting to see how things benchmark, it is more important that we look at, as Dee mentioned, it's about the themes, it's about what's happening internally rather than worrying too much about what's happening anywhere else, because it's very difficult to measure organisation against organisation. I think, Tony, that's probably reflects your experience.
Yeah, definitely, Helen. But I fully agree. We do need to look at the national themes and see whether or not where we're different to what the national themes are. Traditionally, when they publish this kind of data, we're pretty much on a par with what's happening nationally. And there's always there's a high percentage of white British females who are reporting nationally. So the Guardians across the entire country are trying to focus attention on creating more reporting from different minority groups who are working within the NHS.
Thank you, Tony. Right, I don't have anybody else wanting to ask a question. Thank you very much for the report. Just before we move off stroke, it was interesting actually speaking to our consultant and the manager of the unit, is that it's a 27 bed unit, and it's just an indication of what the challenges our colleagues have on a daily basis, where on the actual ward there was 11 people who were medical cases rather than stroke cases, and we actually then had some people who actually had a stroke who unfortunately were in beds in other parts of the organisation. So moving people around and trying to get them to the right place is a constant dilemma for colleagues. But something that I actually wasn't particularly aware of is that we introduced a new acute stroke pathway, a hyperacute stroke, where someone who actually has a stroke either goes to Sheffield or to Doncaster, and after they've had their initial 72 hours review and actually treatment and support, they then actually get returned back to the host town, as it were, so back to Rotherham. But on quite a few occasions, when they're ready to come back from either Sheffield or Doncaster, we sometimes don't have a bed for them. And so therefore that creates problems, you know, on the broader system, but also brings penalties with it as well. So we actually get a charge if we're not able to take them back on a particular time. So it's the complexity of just that one small part of what it is our colleagues are dealing with. It is, as I say, that daily challenge. And we were assured that there was every effort being made to get patients in the right place at the right time, but the pressures as such are just significant. Zlaka?
Yeah, Martin, Tony, my
Sorry, we can't hear you.
Sorry, Tony, my reflection when I'd read the report was about minority workers and about had we had any minority workers coming forward, and if not, it's part of that work about building their confidence in being able to feel that they can come forward and report.
It definitely is Lacquer. For the last couple of years now, we've been working really closely with Emily Rowe's team from the EDI perspective. We jointly launched a Call It Out, Work It Out campaign. We're heavily involved in that, and we've actively been recruiting guardians from all different kinds of backgrounds. So we try and be as accurate as reflection of the workforce as possible. I have spoke to some different staff over the last couple of weeks and trying to convince them to join as well, because there may be some vacancies coming up within the Guardians over the next few months. So it'd be great if we could get some different other minority groups, because the trust is changing and it should be a reflection of the local community.
Yeah.
And I think we're gradually getting there from where we were a couple of years ago, but it's still a lot of work to do.
Okay, thank you.
Thank you. Thank you for everybody's contributions, and thank you, Tony, for your report. Good to see you.
No problem. Thank you, Chair.
Moving on to the next item on our agenda, which is health inequalities update. Again, quite a comprehensive report presented by our Deputy Chief Executive, Michael Wright. Anything in particular you want to highlight, Michael, please?
Yeah, thank you, Chair. So you can see that there are a number of schemes that are in progress and we're definitely getting traction. Some will have clearly tangible benefits, others will have benefits which will be intangible. And we need to really start to focus on how do we measure the successes. So some areas will be easy, for example, the did not attends in the more deprived areas. The actions we're putting in place should see an improvement, but we need to measure that. And another key development is the public health consultant, which is the joint post shared with RMBC with a successful post holder starting on the 1st of March. And if it's okay, Chair, could I just bring Louise in? I think Louise has got a couple of points to make as well on this, having done quite a lot of the work.
Yes, please. Thank you.
Thank you, Michael. So, so I think that there's three things I wanted to say really about this report, a couple of which are maybe obvious in there and a couple of which aren't. That's up to four, I'm conscious of that, but I think there's just three. So the first is that in the report, you will have seen the mention of us being successful in terms of our application around the National Digital Weight Management Programme. And I do think it's just recognising that in terms of, again, for the organisation, there are 10 providers nationally that have been offered the chance to participate in that. And I think that the fact our trust is one of two in northeastern Yorkshire, our region, is fantastic for us, and actually fits really well with the needs of our population. And we recognise that right at the start of this programme of work, in terms of the needs of our communities and equally the provision that we offer. And so I think that's a huge positive for the organisation. So I wanted to just recognise that. Michael's mentioned the public health consultant, so I won't go into any more detail on that. But I think the third thing I wanted to just pull out, which is implicit in the report, but I think is important to recognise really clearly. One of the things we're very keen to do, and we have been keen to do this year, but through the strategy as well, is make sure we're involving our patients in what we're doing. And earlier on, we were talking about outcomes, and Heather raised that question, but I think what's evident from some of the work we're doing now is that it is absolutely about that direct contact with patients and conversation with patients about what they need from us and how we can best provide that service to them. So some of the work that we're doing around why patients aren't attending from the more deprived areas, we are going to be phoning those patients individually and having conversations with them. And that's an investment in time and resource, but I think it speaks to the heart of that, making sure we're hearing that patient voice and we're really interacting effectively with our patients. And similarly on some of the waiting well work that we're doing, one of the things we're looking at is how we have those conversations with patients about their situation and kind of the wider holistic needs of those individuals and how we can then make sure that we're responding to those appropriately. So I just wanted to pull that out because it's not necessarily as evident in the paper as it ought to be. And just adding on Michael's point about metrics, I think the one area where we need to do some more work, and I'm excited about the Rotherham Office of Data Analytics and that launching. So you might hear that acronym referred to sometimes as RODA. So that's due to launch soon. I think we do need to do some further work around our urgent and emergency care attendances and linking up that across placement with primary care around how we can better support as a place those patients. I think that's a piece of work that we've started, but we need to continue that and see it through to make sure it has an impact for our communities. Thank you, Martin.
Thank you, Louise. Rumit, Sally and Zlaka.
So yeah, my question specifically about the National Digital Weight Management Service, and that is that it's excellent that we've been awarded this, and it's very, very useful that we've got access to this service. But in terms of measuring success, how are we going to actually measure success, i.e. the appointments are there, people are actually taking it up, and with it being digital, how our health inequalities going to be addressed with regards to digital? Because not a lot of people like to have weight management digitally, but it is still there for people to access. But how do we measure that success?
Thank you, Umit. So I think one thing to point out to start with is that this programme is very clearly in its infancy, but in a positive way. The programme team have demonstrated a real desire to learn from us about what would work best. So they're not actually coming to us saying this is what we have to do and it's this set way and that's it. They're actually coming to us and saying, well, what would work best for you, your teams, your systems, your processes. So I think that's really positive. I think some of the questions you've asked are actually for us to define as we go through this. We've only started that initial conversation in the last month or so. However, in terms of your point around health inequalities, I think that we know that there is a direct link between obesity and deprivation levels. And I think whilst we haven't got the evidence yet, in terms of COVID, that's potentially been exacerbated, although I haven't seen any recent evidence on that. So I think this will naturally impact and benefit some of our patients in these more deprived areas. It is focused on just a few particular procedures that we offer. One is around orthopedic procedures and one is around hernia surgery. There's a further one around bariatric surgery, but we don't offer that as a service here, so that's not that doesn't apply to us. So there will be a relatively small cohort of patients, and we are going to be provided with patient level data on who accepted it, who took it up, who completed the course. So we will be able to do that evaluation piece. I think the national team see that as critically important. So it definitely will be a part of the programme of work, but in terms of the specifics, I think that's up for grabs a bit and it's up to us to define.
Thank you. Sally, Zlaka and Heather.
Thank you. Just a quick question really in relation to the what we're doing around DNA rates and understanding some of the reasons why we see that difference. Is there any early learning, Louise, yet around what that's telling us that we can build into the work we're doing about from an outpatient redesign perspective? I know it's conversations we've had in that space in terms of the changes we make from an outpatient redesign point of view, and that it doesn't have any negative impacts from a health inequalities point of view. So is there any early learning that we can share that we can build in there?
I really wish there was, but not yet, Sally. But definitely, as soon as we have that, I completely agree. It's really important we link that into what we're doing more widely around outpatients, but not yet, I'm afraid.
Thanks.
Thank you. Zlaka, Heather.
Okay, so when I was looking at the report, I was trying to see whether there was any figures around backgrounds of communities. So I was picking up the language about deprived communities and did not attend, for example, but I couldn't tell. So that is something that I'm always interested in and would find useful. And linked to that is a question about, in terms of our needs assessments, how are we ensuring that we're getting a cross-representative information of all the different communities? And the final point is, so when I was reading, for example, about the smoking cessation, I know that within certain communities, there's shisha smoking or hookah smoking. Some communities have, there's another type of smoking that's used. And when I've worked with those other organisations at times, they've usually not included all of that information as their baseline. So again, I suppose my questions are, how as an organisation are we ensuring that when we're looking at needs, that we're taking a full account of all of the experiences of our communities?
Thanks, Zlaka. So I'll take those in turn. I think in terms of ethnic minorities point, it's a really fair one, and I know Joe was really keen that we included more information around that as well. I think one of the very pragmatic things we ought to do is that when we look at the health inequalities in our dashboard at the moment and our IPR at the moment, we do cut that by deprivation quintile. And I think it's like one of the things we can quickly do, and we do have it available, we don't share it here, is make sure we're doing that same piece of work around our ethnic minority communities. And for us, that will break down into BAME and non-BAME, because otherwise you get to small numbers at points. So I think we can commit to do that for next time. In terms of your question around needs assessment and smoking in particular, I think is a really interesting one. I don't know the answer to that in terms of do we include other types of smoking, but I will absolutely go back to the team and make sure that's the case. But I think your more broader point about needs assessments and ensuring that we're involving the whole patient in that is the one bit of assurance I can give you here is that we have our patient experience team and our head of patient engagement are incredibly key to this work, and they do a lot of outreach work with our communities. And I think it's important probably that you have a conversation with our head of patient engagement, because she'll be able to give you a lot more information. But it's through those discussions and building in those individuals that we do that, and also linking directly with those patients and with our clinicians as well. But I would suggest that happens subsequent to this meeting. Zlaka.
Thank you.
Thank you, Louise. Can you arrange just to put Zlaka in touch with our head of engagement, please, after the meeting? That would be helpful. So Heather and then Joe. And sorry, Heather, we'll just finish with Joe, please, on this particular item, as she actually chaired the Health Inequalities Task Force when originally established. Heather.
Yes, thank you. Just picking up on what Louise said there about listening to patients and having conversations with them. I think there are some massive opportunities to have a fresh look at the way we deliver some of our services. So when we're talking here today, we're talking, for example, about smoking, weight. You could add on alcohol, you could add on etc., etc., etc. And if you look at some of the work that's been done within the community division, rather than looking at it as a specific task or an issue or a specific health issue, many of these patients who struggle to get to the different appointments have multiple issues wrong with them. And Rod Kirsch has been actually operating some clinics whereby various consultants from different disciplines attend a session whereby a patient can basically get all of their different issues addressed in one visit, and they move from one room to the next room to the next room. And I think that is turning our service on its head, and it's probably quite a complex thing to organise, but you address a lot of different issues in one go, which works for the patient and addresses a lot of their health needs. So I think when we're looking at where we go forward and reconfiguration of some of our services, I think that would be a very powerful way of addressing some of the do not attends, etc.
Thank you for sharing that, Heather. Thank you. And finally, Joe, please.
Yeah, thank you. So there are a few things I just wanted to reflect on. So first of all, say, thank you and great work from all the colleagues who have really, I think, taken this agenda very enthusiastically forward with a lot of commitment to what we're trying to achieve. And it's been great to see that. I mean, I think, as we know, health inequalities, the deep structural problems, it's hard to change things quickly. So many of the things lie outside of what the trust does. I think one thing I'm also conscious of is that, we have the challenge of the health inequalities that sit within Rotherham as a place, but also actually Rotherham, when you look nationally, we know health outcomes in Rotherham, much poorer than many other parts of the country. So I think there's something there as well, that actually everything we do is so important to addressing the national challenge around health inequalities, as well as making sure we're sort of focusing on the groups with greatest need within Rotherham. I think the plan with Louise and Michael in the new year is we'll reconvene the task group just to sort of take stock and think about what we can take forward next. I mean, it's such a huge agenda. I think our approach has been start somewhere, get some impact, build confidence, and then build on that. And I think that's definitely what we've seen happening. So that's great. And then the final reflection I just wanted to make is that in the kind of evidence base around health inequalities, there's quite a lot of evidence emerging now about how bigger societal shocks have an impact on sort of more disadvantaged communities. A lot of data now about the impact on austerity, on sort of life expectancy and so on. We saw it in COVID, the most disadvantaged communities faring worse. And with us going through the cost of living crisis and all the pressures, I think, we've got to be really conscious that this is another huge societal shock to the nation, and everything we do now, we really have to have the sort of most disadvantaged communities in mind to make sure that they don't fare unfairly and worse in this situation.
Thank you for that summary, Joe. That's very helpful. And so we'll note in the minutes that the task and finish group are going to reconvene just to reflect the progress that we're making, and no doubt we'll have a further report to the board in due course. So thank you for the report, Michael. Thank you, Louise, and for everybody's contribution. So moving on now, if I may please, to the board development item that we have presented. That's there just to really recognise the fact that we've had a programme of board development, and it's a time now for reflection and for us to decide what the next phase of our board development is going to be, and we'll be considering that at our February meeting. But one thing I'd just like to highlight is in the review of how the board is working, one of the key points that came out was that as a board we ought to focus more on culture as part of the board agenda and part of the remit of the board. So you'll note today, obviously, we've got a section on our agenda which actually is culture, and you'll note there that the timing is I've given more time to that particular culture section. So as a result of that, I'm just mentioning that is because clearly as we come to other items on the agenda, we just need to be mindful of the fact that we have focused more onto those cultural issues. Any comments really, or just happy to note the report? Okay, let's note that report and thank you. The next item on our agenda is reciprocal mentoring for inclusion, as it's titled there. And Steve, you've presented this report. Is there, again, anything you'd like to particularly add to what it is you presented, please? Thank you.
Thank you, Chair. I think I can be relatively brief with this because colleagues will recall that we had a session at the development session of the board last time around reciprocal mentoring, which I think was well received. And in particular, we heard from Precious Keita and Haj Kyra, who've been a couple of the participants in the reciprocal mentoring scheme, and gave a fairly powerful and sobering reflection of their experiences of working within the organisation. By way of updates, Richard, Jenkins, myself and Emily have met with Precious and Haj to go through some of the recommendations that they put forward from their learning and experience within the organisation. And we've talked about that, and it's a really, really positive meeting, and a couple of things that came out of that. One, I've given them, I don't think I needed to give them permission because they're fairly formidable advocates, but they've got ready access to me, which I think they've appreciated in terms of my kind of an open door to bring any issues, concerns, blockages within the work that they're doing to my door as an advocate for the reciprocal mentoring programme, and also for the work that Precious and Haj are doing. And I think that was well received. And they also were very appreciative of the audience with Richard in terms of the seriousness with which the organisation is taking this. So we spent quite a long time going through the detail of their recommendations. They were very clear about the size and the challenge of the problem in terms of what can be achieved within the timescales that we've got. But we've included some of the recommendations that Precious and Haj were keen on in the Res Action Plan, which is attached, which is an addition to the paper that was submitted to the board last time. One of the things, and thank you for your feedback, Martin, it's not explicit in the action plan. We are going to continue with the listening sessions for Black and minority ethnic staff and maintain that momentum going forward, and at some point make that business as usual for the Black and minority ethnic staff network. Precious is now the deputy chair of the network, and so I think colleagues will pick up from Precious's input. She's got the drive and the ambition to take that forward. I think every NHS organisation I've been involved with, sometimes it's difficult to get those staff networks off the ground. It's off the ground, and I think with Precious's involvement now and protected time, she will be able to take forward and drive that forward with the support of Emily, myself and other colleagues as part of the reciprocal mentoring programme. So I'll pause there. I'm happy to take any questions or comments or feedback from the session that we had last time, because I think we did that as part of the development session, so it wasn't part of the public board. I think it's important that it's in the public board today, so I think our staff and the rest of the wider community can understand how seriously we're taking this issue and the work that's already gone on. So happy to take any questions.
Smashing. Well, thank you for the report, Steve, and also for following it on. And I'm pleased that time has been put aside to obviously focus on this very important issue. And as a board, we have been really concerned about the whole equality diversity programme. So it's good to see something practical moving forward that can be hopefully sustained. I've got a number of colleagues who would like to make a contribution. So I've got Joe Bean first, please, Joe.
Yeah, hi, thanks, Steve. Given that, just thinking about medical and dental staff, I know we've got a high proportion of ethnic minorities in our medical staff, but also that we're scoring poorly for the medics in diversity and equality comparatively to other staff groups. How much representation has there been for medical and dental staff in the reciprocal mentoring programme?
I think it's fair to say, Joe, it's limited, which is, I suspect you probably knew the answer to that before the question. I think that, again, is a feature in many NHS organisations. We are intending to try and address that. And in particular, we're doing some specific work within the surgical division around some of the issues around culture, equality, diversity and inclusion. And that we recognise that's going to be challenging, but we think it's important. And we've engaged an external facilitator to try and support us to do some work in that space, but we know that that will be challenging. But on your wider point, we do intend to involve medical and dental staff more in this work, and also I think part of what you'll be doing around medical engagement in general, but specifically from an equality, diversity and inclusion perspective.
Yes, certainly just to feedback, so I know some of the plan will include it in the leadership programmes that we're developing and as part of our medical engagement. Thank you.
Well, that's good to hear, Joe. But also just to share with you is, as part of the workshops that I was engaged with, is we do actually have two of our consultants who have participated and have actually expressed a willingness to actually engage in this programme and to offer their experience, because both of them have probably been practicing in the UK for 25 years plus and feel as if they can actually support colleagues. And that was a real positive move. So I'll make sure that the names of those consultants are passed to you, Joe, for you to follow up. That would be good. Cameron and then Jodie, please.
Thanks, Martin. Yeah, I just wanted to reflect on some of the real sort of successes here and how we can use that in other areas. So, you know, as Steve was talking, there were a couple of key phrases that jumped out to me. One of them was protected time. You know, we've taken the priority and said, like, we're going to protect this, we're going to prioritize this, and it's worked. And it's also, you know, having people like Precious and Harsh champion this, that's worked. You know, so there's a number of learnings here. I think we just need to sort of capture under the banner of maybe culture change and just make sure that we revisit this as a sort of working model and you know, proof of success. So I just want to reflect that back.
Thanks, Cameron. That's really, really helpful. I think it does speak to the need to give. We can say that we're interested in this, and we can say that we actually need to give the time for people, and particularly going where the energy is, to give people the time to actually do it and take it forward. So that's really helpful feedback, Cameron.
Thank you. And finally, Jodie, please.
Yeah, thank you, Steve. I was just really encouraged to see the suggestion around doing a programme across place, because I think it mirrors a lot of the work we're trying to do collaboratively across place and extends that opportunity around the culture we're creating across Rotherham. So I think that's a really great idea for us.
Yeah, thank you. We were a little wary, but I think it's important to do, and we've got the connections within place now that I think we can widen that reciprocal mentoring across the place, and there is enthusiasm in terms of place colleagues and partners to do that, so hopefully that will have similar success.
Smashing. Well, thank you very much for the report, Steve. And when we approved the RES action plan, we also said that that actually was a dynamic plan, and we'd keep it under review. And this is an example about actually adding to it as there are, you know, good things that we can actually pursue and hopefully deliver. So coming back to the recommendations, is rather than taking the recommendation that is on the summary report, can we go to recommendations at section 5 of the report and actually incorporate those recommendations for approval by the board? Are we all agreed with those recommendations, please? Thank you very much. Thank you very much for the report, Steve. So that's the section that we've been dealing with regard to culture. We've now got a report on system working, which is quite a comprehensive report, as it always is, because it's capturing national and the Integrated Care Board for South Yorkshire system and the Rotherham place. Again, comprehensive report. Could you just highlight any key points you want the board to be aware of, please, Michael?
Yes, thank you, Chair. In addition, just to note in the Rotherham plan, which is appended to the paper, just a key area of focus has been our joint work with RMBC and Rotherham Place ICB colleagues around the integrated discharge work that we're doing together, with a view to getting these 72-hour patients who've been for a period of 3 days and over to an absolute minimum. That did get a lot of traction before Christmas, and those numbers did fall significantly for the 72 hours. The bank holiday period did adversely impact us, but we've started to see some recovery again. And at that point, Chair, I'll pause and take any questions.
Thank you very much. Michael, any questions or comments on the report? Okay, just a couple from me, please, Michael. Sorry, Joe, if you're going to comment.
Sorry, I was struggling to find the hand. Yeah, no, thanks, Michael. Really interesting to see, and it was really great to see the Rotherham Place plan that was attached. And they talk about inclusive economies and anchor institutions as a kind of part of that. I just wondered if you could say a little bit about where the trust is at on its role as an anchor institution.
Yes, certainly. So we have been involved in a lot of recruitment initiatives down at New York Stadium, which is a Rotherham football ground, where we've reached out to the wider community, particularly residents who are currently unemployed, with a view to recruiting. We've also been looking at local spend, which you go through our procurement team. The local spend for 2021, I do have that, and the more recent spend is coming towards me very shortly, but that equated to approximately £4 million. So there's quite a bit of work that we're doing in that space at the moment.
Okay, thank you, Michael. With regard to the Rotherham Together partnership plan that is attached there's obviously quite a section on health related items, and if when we're developing our operational plan over the next few years, obviously let's just be assured that we, as a key partner within the Rotherham Place and within the Rotherham Together partnership, that we're just actually embracing some of those particular key points where we can. And if we can't, of course, is ensure that the partnership are aware over what it is we can contribute to and what it is that we can't. That would be really helpful in just sort of ensuring that we are participating in that overall strategic plan for the borough and ensuring that we play our role in it. Michael, please. Michael?
Yeah, absolutely. And when the plan was developed, there was a stand in our reception area in the trust where patients and staff members were able to contribute. And then slightly not linked, but there is a Rotherham Place plan that sits outside of this that is more of a focus on health. That will be being refreshed very shortly as well. And there's a session next week to engage in what the future plan will look like. But we'll make sure that happens, Chair.
Thanks very much. Thank you for that. So there's no approval we need to make apart from noting that report. Thank you. Moving on to the strategy section of our agenda. The next item is the trust planning process. And again, Michael, we're working quite hard this morning. So again, if you could highlight the key points for the board, please.
Yeah, thanks. So I think the key points are, you can see there's a lot of collaboration there between the exec team. So Steve, Sally, Louise, and ultimately myself are heavily involved in this. We want to understand the capacity and what the delivery is going to cost. Louise has done a lot of the legwork on this. If it's okay, I'd just like to hand over to Louise to bring out a couple of points, please, Chair.
Thank you.
Thank you. So just a couple of things before we move on to the decision that's requested from the paper, Martin. So as Michael said, this is a collaborative effort. I think, Cameron, you referenced earlier on the planning guidance, and obviously that landed with us just before Christmas. And at that point, it's the high-level operational deliverables that the national team are asking us to do. So just to link back to your question earlier on, we are currently going through a process with the executive team of confirming our priorities for next year. And as part of that piece of work, we will go through pretty meticulously, as you suggested, and identify, which of these are we going to deliver, which of these may not be relevant to us as a provider, which of these are we going to be able to deliver in part, but actually there's some reason why we can't deliver them in full. So that will form part of that process. So I think that's just important to note given the question. But at that point in time, and still now, we don't have full clarity, and Steve may want to say more about this, around the funding regime and set up for next year. So we have indicative guidance, but we don't yet have full clarity on what that might look like. So again, this is a process of us being as prepared as we can, but also recognising there needs to be some flexibility around the timescales and the deadlines that we're working to, because actually there will be more guidance that will come through in the next few weeks, and that may change decisions on things and how we need to work. So I think those are just a couple of points I wanted to bring out. I don't know if Steve wants to come in, but there's certainly a decision to make at this point, which links very closely to the financial plan. So, so Steve, happy if you want to share your thoughts on that one.
Thanks, Louise. Thanks, Chair. Just so briefly, in terms of some of the assumptions around financial allocations, Mark Bloy, my Deputy Director of Finance, is attending a South Yorkshire meeting as we speak, so we may have further intelligence around allocations come the end of the day. We believe that South Yorkshire, as an integrated care board, have actually received an allocation for the whole of South Yorkshire, but clearly therefore acting as a commissioner, then they need to engage in a process to actually make the allocations down to organisational level, and that process has not been concluded, and we've yet to find out what those allocations will be. Typically we have been made aware of some of the downsides, so COVID funding not being as much as we've had in previous years, and convergence funding which will be detracted away from allocations. So some of the downside has already been explained, but we're yet to find out what the core allocations will be. So as Louise has said, the timescales are really tight. We're working to the assumption that we have to submit final plans by the end of March as per the national guidance. So trying to fit that into Finance and Performance Committee and board schedules is difficult in terms of timing. So there's a couple of options there in terms of recommendations. Either board could be comfortable to delegate to Finance and Performance Committee on their meeting of the 29th to approve the final submission to the centre, or we think about board convening a special meeting, as we have done in previous financial years, in terms of making sure that we've got a date in diaries before the 31st of March to cover off the governance aspects of submitting the final plan. So hopefully that's a little bit more information, Chair, in terms of the context we're working in. But obviously there we've got a choice as board colleagues to make around whether we're comfortable for FPC to oversee the final process, or whether we want to convene another meeting. So that's the question for today.
Okay, thank you very much, Steve. Well, I'll just actually clear that question up then, because we're not delegating any approval to an assurance committee. This is a matter for the board, and it's a key role for the board to be signing off its plan. So you'll have to factor in appropriate mechanisms for the board collectively to make that decision. One of the things that I'm not too comfortable with is that I can't see actually the processes for engaging the board really in this. And it's not a matter of the board just seeing the plan at the point of actually approving it. We need to actually engage the board in part process of actually the development of it. So we do in fact have a strategic board in February. So I would like you to ensure that the programme is adapted to ensure that you can use that time to ensure that the board are actually taking along with the plans as they are actually developing as part of that process, please. So it's very important that we factor a couple of key stages for the board's engagement. So thank you for that. I've got a number of colleagues who'd like to contribute. So Heather and Cameron. Heather.
Thank you. I've just got a few points to make / questions. Somewhere in the detailed planning guidance, there seemed to me, unless I misinterpreted it, a hint that it might potentially be moving back to activity-based funding rather than block contract, and yet our assumptions, and I appreciate this may be timing, say block contract, and that could have quite significant implications for us. So I just wondered if maybe Steve could touch on that. One item of concern for me was where it says that the requests are that capital is essential schemes only, and how we made sure that tied into our strategy and also our medical equipment replacement plan that we developed. And then the final point I wanted to sort of make in terms of sign off and approval of the plan. Yes, we've got the financial plan, but we've also got all the operational plan, and it's the development of those operational mandates in detail so that we go into the new financial year with everybody knowing exactly what we're going to do and how we're going to measure what we're going to do, rather than it being developed over the first quarter. That's an aspiration we've had for many years, and I think it's something we should actually deliver on this year.
Thank you, Heather. You want to comment?
Yeah, thanks, Heather.
Thank you.
Two really important points that you've made there. Yes, there is a strong indication that we'll be moving back to some form of elective, so payment by results type activity. We're pretty confident that that will only relate to elective care and will not relate to non-elective care. So block will still remain for non-elective care, UECC activity, etc. Again, we're still in a little bit of, we're still in the dark a little bit as to what exactly that will translate into. So that the precise detail is not known. So again, we're working a little bit blind in terms of the information, which again makes this timescale really challenging in terms of working all that through around risk to the organisation, either from an activity point of view or from a financial point. But we're pretty certain that some form of payment by results on elective activity only will come back into play for 23-24. And clearly, as you indicated, that may bring some risk to the organisation. In terms of your second point, Heather, around capital, so it does indicate there around essential capital expenditure. We are anticipating a relatively stable position on allocation funding, so around about £10 million before any additional items could potentially come into play. So we are anticipating around about a £10 million allocation on capital, but again that will be worked through as we go through the planning round, and that's the numbers that we've been working on now for a while in terms of allocation. So I'm hopeful that we will be able to have a similar allocation around medical equipment replacement as part of that allocation. But clearly that's a process that we need to go through. We've asked divisions already, and James and Ian, in terms of their respective areas, to put forward capital programme allocations for next year, and we will consider that a capital monitoring group. I think it's later this month in terms of the first draft. So I'm not anticipating that there'll be a significant reduction in capital allocation, but again, we're in the hands of the Integrated Care Board for final allocations.
Thank you, Steve. Cameron, Sally and Joe, please. Cameron?
Thanks, Martin. So I was just going through the planning principles, and at least on paper, the one that's missing for me is how are we making sure that we're staying relevant to user needs, patients' needs? Because ultimately, there's going to be trade-offs as to where we allocate finite resources. And, so there's pointers like, okay, we should try and achieve 1920 activity levels. Well, are they still relevant? So as a board, I think, we need assurance that we are actually reflecting the needs of the user and patients, and they are relevant today, not just, historic trends. So I'm kind of looking for something that says, yes, we are actually taking that into account. We're not just running a process based on historic data, historic budgets. We are relevant today with today's needs. So I was kind of seeing, I thought that should be one of the main principles.
I think, Cameron, we ought to give you an audience with the national team, I think. to obviously ensure that they're reflecting those kind of comments. But I think your point is well made. Really, is that our plans must actually be delivering the purpose why we are here in those situations. So let's make sure that sort of Cameron's comments resonate, please, in this next phase. Thank you, Sally, and then Joe, please.
Thank you. Mine was just to pick out in terms of the planning process and planning guidance that there's a very clear indication now that we will be returning to a 4-hour standard. So it's clear in the planning guidance that nationally they will remain with that. But we have had conversations now with the national team as a field test site that we will be returning to a 4-hour standard on urgent and emergency care. So it'll obviously be a large part of our operational plan for next year. And we're already in the process of planning how we return to that and reintroduce reporting on 4 hours. So I just thought it's worth highlighting that to the board, because it's such a significant part of it for us operationally.
Yeah, thank you for highlighting that. Thank you. Right, I've got the last two now, please. I've got Joe Bibby and then Heather. Joe?
Yeah, I had a question. So thanks for the paper and also the sort of briefing slides on the long-term plan and so on. It was really informative. I mean, we do know the challenge with the NHS is that it works on annual planning cycles, yet delivering a healthcare system, really does need much more long-term planning, particularly around our workforce. So I just wondered if we think there is any opportunities as divisions are doing their capacity plans for kind of, the coming year, how we can encourage that to be sat in some wider thinking about sort of future-proofing our workforce rather than just focusing on the next year because we've been asked to do that, but we can situate it in that longer term thinking.
Are you coming back on that one, Michael?
Yes, please, Chair. So no, it's a relevant point, Joe. I think a big issue for us is around retention. And we'll see later on in the slides when we talk about health and wellbeing and sickness. We'll touch on retention. Helen and team, particularly Cindy, have been doing a lot of work on nurse retention. And I'm hopeful we'll see some traction on that, and that will start to make a difference long term, definitely. But it is something that we need to think about.
Okay, thank you, Michael. So finally on this item now, Heather.
Just picking up on what Sally said on the 4 hour, which is obviously quite an emotive, easy headline for the public to get their heads around and therefore for the NHS to report against. But some of the things that we've done as a test site have actually improved significantly the flow through A&E. It's just an assurance that we won't just go back to just 4 hours, but we will continue to do some of those things which have improved things for our patients and flow.
So if I just come back in on that, Heather, absolutely. And I think it's really important we don't lose the learning and the important things that we put in place to respond to that, particularly in the early days and really doing things differently. In our initial reflection is that a lot of that, all of the good stuff that we've done will be able to remain in place. What we need to do is some of the pathways that we've got, that they take place outside of our urgent emergency care centre so that we can become compliant with the 4 hour standard. A lot of the work that we've done already does take place outside of the UECC, but there are aspects of work and change that we've made that's improved pathways, but is it within that environment? So there's a lot of work to do around environments and where patients are seen.
Okay, thank you. So Michael, Steve, can you bring me now to the recommendations really that we need the board to make, please? Hello?
Apologies. Yeah, apologies. In terms of the recommendations, I think we are recommending that the board support and approve the plans that we have in place to develop the financial plan, capacity plan and operational plan, subject to more engagement with a board at a strategic meeting with a view to us then bringing back something formal, ultimately with agreement from the board that will come via F&P initially as well, but ultimately for board endorsement and approval.
Okay, thank you. With that recommendation, which hopefully, Dawn, you can capture in the minutes for us, are we all agreed? Thank you. Thanks very much. So looking at our agenda now, we actually have Sarah Petty, our head of midwifery, joining us at 10:25. Is actually Sarah with us, please, Dawn?
Yes, she's in the waiting room, Chair.
Smashing. So if we can invite Sarah in, and we'll go to the item P2223, which is the maternity safety, including Ockenden. You'll note on the agenda that we've got 5 minutes for this. So if we could be mindful of that, please, as we're addressing this item, please. So I can come to you first, please, Helen, in terms of introducing the key things that you want the board to be aware of this month.
Thank you. You do have your Ockenden paper, and Sarah will obviously address any questions you have around that, but really we want to use this time just to focus on the annual submission of the CNST data that we need to sign off through board, well, through Chief Exec within the next month. So I'll hand over to Sarah, who can give you the key highlights of that process.
Good morning, Sarah. Welcome to the meeting. Sorry, is Sarah with us?
It doesn't appear to be on the screen.
No, I can't see it. Can I? Dawn, is Sarah still there?
She must have dropped out, Chair. She's coming back in now.
Hello, Sarah. Good morning. Welcome to the meeting. Would you like to just say what you said before Sarah joined us, please, Heather, so that we can be on what we need this morning?
Thank you. Yes, I was just explaining that although Sarah will be happy to take any questions around the Ockenden and regular monthly submission, she will focus for now on the CNST data that we need to sign off for our annual submission. So I'll hand over to Sarah.
Thank you.
Thank you. Good morning, everybody. Apologies, Zoom threw me out when I joined first time, so nice to see you all this morning. So yes, as Helen says, we're just going to focus on CNST today, if that's okay. So that is page 5 of the paper. So we'll take it that you've read all the other items on the 4 pillars. So as discussed at the last board meeting, and we've done a number of confirm and challenge meetings going through all the evidence for CNST. And to make sure that we've had a really robust process, we've also had an executive lead to go through all the evidence as well, which has been really, really well received. So thank you all for your support with that. So it's been through quality committee, and we did present the presentation last month at executive team, and it did feed through to trust board. So what we are bringing today is the trust declaration form for approval that we can have CEO sign off by Richard of the CNST sign off form. I just want to bring to your attention that we were declaring full compliance with all 10 safety actions. However, through the QA process, it has come to our attention that we have had an issue with safety action 1. Now, this was one of the cases for the PMRT. So safety action 1 is the use of the PMRT for perinatal deaths. And when we went through the check and challenge, there was one case that needed to be reviewed because the time period was up to the 5th of December. So when we went back to recheck this case, it became apparent that we had not met the timeline for that. And that was due to the fact that another trust needed to report on the inputs on this perinatal death. And that gave us a 3-day turnaround. So for this action, we needed to be 95% compliant with the review tool and starting the review. And because that timeline had been missed by 6 days, and it was actually 3 working days, that brought our percentage down to 86%. Now, that is because of us having small numbers in a DGH. So one case will affect us quite negatively, whereas in larger organisations, that is not the case. So we brought this to the attention of Embrace, and we have received emails to say that they are very sympathetic, and that is something that will certainly be looked at during the verification process. But because of that, the standard is that we declare compliance for 95% of all deaths. And as I've said, we're at 86%. So we are recommending, we're bringing it to the board for agreement that we actually declare that as a red, but we do put mitigation in, and we will put that in the action plan and the supporting information just to explain the mitigation that we had with that case.
Thank you, Sarah. Well, I'm sure that the board would support that suggestion that you're making. Are we all agreed with that? Thank you.
Yeah, yes, sorry, Chair. Can I just quickly ask for, if we are waiting for a report from another trust, who is accountable for the delay in that happening?
Yeah, there wasn't a delay, roommate. That's the problem. They did bring it back with us within time, but when they brought it back, we had 3 days to close it.
Right.
To finalise the report. In the current climate that we're working in, that is really challenging, you know. And so for the first part of the safety action, the standard actually states that any trusts where a trust is needed for other information, then that would actually not be required. But for this element of the safety action, it isn't mitigated against. But as I've said, we have contacted Embrace and they do recognise that. And this has never happened before. You know, it's just typical, isn't it? It's one of these cases where this has never, ever happened before. But this is the robustness of our QA process, I suppose. You know, this is why we do what we do and we check. And we've gone through the cases to make sure that we're absolutely right. You know, and I am hopeful that will be taken into consideration.
Yeah. Thank
you. Thank you. Dee, and then Michael. Dee.
Morning, Sarah. Thank you for that. And thank you for your honesty. And there's no question that we should only declare what's actually right against the guidance and put the mitigations in. And I suppose the difficulty is, if it's a one-off, is there anything that we can put in place that alerts us to this a bit earlier in the future, or could we prevent it happening again?
Thank you, Dee. Yeah, absolutely. We've already got some processes in place to stop this from, you know, from happening. This is one sort of person's role where they are responsible for this inputting of the data. So that's not always sustainable. So we have already recruited to another person who will support that, and we've got an infrastructure in place in governance to support that as well. But what we're going to do now is the sort of tracker that individual has in their office, we're going to put that through governance as well each month, just so we've all got that oversight as well. So it's a shared sort of responsibility in that respect.
Thank you. Michael Wright.
Yeah, thanks. Thank you, Sarah. Absolutely right. That we're open and transparent and honest. What is the potential impact on the trust? Is there a consequence attached to it?
Well, the consequences, Michael, is if it's not looked upon favourably, is that we won't pass that safety action because that standard hasn't been met, because we're at 86% and we need to be at 95%. However, the email that I've received from Embrace, it does state, just to reassure you, that we are sympathetic to small trusts where one missed action affects the percentage achieved, and we will definitely look at this when we do the verification. So just to give you a little bit more context, for these cases, there is an external verification process from Embrace for the perinatal report, and it is the same with NHS resolution as well. So it's far better, you know, like we've said, to be transparent in that process, and then we can, you know, hope that mitigation will be listened to.
Thanks, Sam.
Thank you. Well, we've actually agreed the point that Sarah was making here. Are there any other actions we need to take, Helen, with regard to this report in terms of the board's approval?
No, I think if people are happy with that, I'm confident that because of the process we've been through, that all of the evidence has been very closely scrutinised by all of the executive team, which has been really, really helpful, because this isn't just a clinical issue, it's for the whole board, and that's been really helpful. And for anybody who wanted to go back to any more information, it's all in the reading room for anybody that hasn't had a chance to go through that. Appendix 4 is that declaration we've talked about. We did discuss that executive team yesterday, this issue around this first point and this non-compliance, and the board, the executive team were all in agreement that this is the appropriate action. We just need to ensure that that accompanying letter that goes with our submission asks them to take into account the circumstances around the involvement of a third-party trust. It isn't a blame factor, but it's a complication that has led to this situation, and that impact has been a small organisation. That means we are adversely impacted in terms of a percentage in one case with a 3-day delay. So I think that it's the correct approach we're taking, and we'd recommend that we now that the board approve us working with the chief executive to get that final sign off with that one red area.
Thank you, Helen. Thank you, Sarah. So we're all agreed on that proposal that has just been outlined by Helen. Thank you. Thanks very much for your attendance, Sarah. Good to see you.
So thank you, Martin. Can I just say one more thing? On the form, there are 2 other areas that are red, but we're just waiting for verification from MIS and from the LMNS. We don't get the form until, we didn't get it until the end of December. So sometimes the wording, what's in the guidance as to what is on the form is different. So we're just clarifying that, but that should, like we said, we've gone through the QA process for that, so that should all be fine. But we're just waiting for that clarification. So I will be working obviously with Helen and Richard on that as well. Is that okay?
Yes, of course. Thank you very much.
Okay, thank you everybody.
Thank you for your time.
Thank you.
Right, colleagues, we've come to a time where we'll just take a natural break now. So if we could close down and then come back, please, at 10:44, if you wouldn't mind, and we'll continue with the rest of the meeting. Thank you. Welcome back, colleagues. Thank you. Now, coming back to our agenda, we're going to the transition strategy for the care of young people preparing adulthood. And clearly there are a number of items on this agenda now we've got to get through. And our meeting finishes at 11:30, so I'm looking to you for support in terms of ensuring we focus on the key issues for the board. With regard to this particular item, it's actually been through the Safeguarding Committee and the Quality Assurance Committee. So do we have any questions on this strategy before we seek approval, please? Anybody have any questions? Jodie Roberts, please. Jodie?
Yeah, it was just a quick one, Helen, around have we sought feedback from any children that have been kind of in this position around transition services and what their feedback is, and are the ambitions based on some of that feedback?
Yes, and the answer to that is yes, we have. So we do have a cohort of children that we engage with. Not as many at the moment as we would like to, but within the whole pack, ambition 3 is very much about increasing that engagement and involvement of children and young people. And it is the need to increase our involvement is part of this strategy. So that's something we will see increasing, but they have been involved in this process.
Thank you. Jo?
Yeah, thank you. I think it's really great strategy, and it's a really important one. It's such an important group and transition point. And the one question I had is about the evaluation, essentially. And I do wonder if there might be some ways in which sort of the evaluation of it and the monitoring could be strengthened a bit. And I say this because, I mean, we're talking about looking at things like staff feedback and patient service user feedback, you know, how many people will we be asking views, how often? I think a little bit more specificity on some of that as you go forward would be very helpful.
I think, Jo, if we accept that as a principle as such, does that need to be any amendment to the strategy itself? I think that's just in terms of the fact that we would like appropriate evaluation of it going forward. Would you agree?
Yes, yeah.
Thank you very much. So let's put that in the minutes, please, as a note for the implementation of the strategy. But on that basis, are we all agreed we'll approve the strategy as presented? All agreed? Thank you. Thanks very much, Alan, for the strategy. Moving on to the monthly integrated report. Again, a lot of information there. Anything particularly you want to highlight, Michael?
Just the ongoing pressures, Chair, around Opal level 3 and quite a few days on Opal level 4. But at that point, happy to take any questions on the document.
Thanks very much. I think it's very important as a board, we formally recognise the pressures that colleagues have been under in recent times and will continue to be. So I think, as always, is our appreciation and thanks to our colleagues really need to be expressed in support of what it is that they're doing. So thank you to the exec team and colleagues for what it is that that you're doing. Thank you. Heather?
It's just a request, really, with the new statistical process control charts. Could we have that fact sheet every time? Because there's so many different combinations. There's no way that I'm going to remember what all of those are.
Yep, certainly we'll do that then, Heather. Thank you. I can see Louise has got a thumb up. Thank you. Well, thank you for that report. Let's move on to the operational report, performance report now, please. This has been presented by Sally, and again, the key issues you want the board to be aware of, please, Sally.
Thank you, Martin. So you'll note that this is a very high-level report, and in line with the board development work that we've done previously, we've kept this as a really high-level summary of the key metrics that were measured against that we want board to be cited on. The detail in terms of the actions being through Finance and Performance Committee, and you'll note in the chair's log later in the agenda that the levels of assurance. You will see that we're compliant with all bar one metric, which, as we've noted, is we're not assured in terms of delivery against all of them, but there's some great progress against all of the others. The key metrics that we're really challenged around, which linked to operational pressures, and it's where the pressures culminate, is ambulance handover, and we have seen some delays in ambulance handovers beyond what we've seen before. Actions have been taken with partners in terms of YAS, as well as internally across the organisation, not just within the UECC, because the answer, as we all know, is around getting flow out of the department to release capacity to offload crews. What I just wanted to touch on is industrial action, and we talked about that earlier in the agenda, so I'll bring in Steve in a second, but particularly Jodie, who's been doing a really good job with the operational teams around our response to industrial action. And the final point I wanted to pick up is in terms of the delivery of this, obviously sits within the winter plan and the actions within winter plan. A lot of that is all in train now. And one of the questions that we were asked previously by Joe in terms of winter plan was around staff health and wellbeing. We had a really good session in November following board when the plan had been approved. Part of that session, we put a real focus on wellbeing of staff and wellbeing, not just of frontline staff, but our senior teams and operational teams that work incredibly hard over winter. Sarah Newbold, our head of engagement, joined that session, and it really was a really constructive session about what more we can do in terms of winter plan. So I just wanted to feed that back because Joe did get us thinking, what do we do beyond? Okay, so at that point, is it helpful to just bring in Steve and Jodie around industrial action response?
Yeah, please. Thank you.
Thanks, Chair. Thanks, Sally. I'll just give a brief overview of the current state of play in terms of health service industrial action, and then, as Sally has indicated, probably Jodie can give a bit more detail around our operational planning to respond to that. So, as a quick overview, the Royal College of Nursing are taking industrial action for the first time on the 18th and 19th of January. That doesn't affect Rotherham because the ballots at Rotherham didn't meet the threshold, so there isn't industrial action taking place here next week from the Royal College of Nursing. We are mindful that other colleagues within South Yorkshire are impacted by industrial action, so Sheffield Health and Social Care, Sheffield Children's, Sheffield Teaching and Barnsley will be impacted by that industrial action. So we are planning for any residual impact that may come to this organisation. You'll know that Unison and GMB, from an ambulance point of view, took industrial action prior to Christmas, and we responded really well to that. And I think the national view was that the number of ambulance calls on that strike day and the strike day that took place this week were significantly reduced. And from an operational point of view, it was handled extremely well, which Jodie will give you an update on. We've received notification this week, the Chartered Society of Physiotherapists, who prior to Christmas have been successful in their ballot, have notified us that they will be taking action on the 26th of January and the 9th of February. From a Rotherham perspective, that action will take place on the 26th of January. And again, we've started the planning process to respond to that. What I'm about to say, I'm going to say because I'll probably never get the chance to say it again. I was in a meeting yesterday with Steve Barclay, the Secretary of State for Health, and so I just thought I'd drop that in, about industrial action planning for the junior doctors. So the junior doctors ballot for industrial action opened on the 9th, on Monday of this week. I think the sense is that of all the staff groups impacted by cost of living and pay awards, the junior doctors are the most aggrieved, and the expectation is that their ballot will be successful, and that they've indicated that they will take industrial action probably in March for a period of 72 hours. So the meeting yesterday was about how to address some of their concerns and see whether there's anything that can be done about that. So I'll pause there and just pass on to Jodie for the operational response.
Thank you. As I'm sure people can imagine, this was quite a challenging time for our team. So there was quite a large, significant time commitment put into the planning, but divisional teams have responded brilliantly to both of the YAS industrial action days. Quite a significant amount of additional resource has been put into support on those days, such as staffing, additional transport to make sure we mitigate as much of the risks as possible. And as Sally said, that predominantly was around enacting the last bits of our winter plan. So we've got additional beds open, which have been supported by additional staff. It also allowed us to expedite some of the transformation work that we had in train. So our RESTEC model, the opening hours, the extended access to that service were trialled on those days and are continuing. And also some of the significant transformation work in the community has been expedited again. It kind of gave people permission to try something different. So on the back of something that was really challenging, I think we've had some real positive outcomes. Just in terms of elective, we cancelled minimal elective activity and outpatient activity on the back of the industrial action with the ambulance service, which I think again is a credit to our teams. and we protected the majority of our elective work at that time as well. So all in all, it was a successful period, but not without its challenges in terms of an additional ask on our staffing teams and additional resource being put in.
Thank you, Jodie, and thank you, Steve, for the update there. And obviously, thank you for the way our colleagues have responded to yet further challenges that they're actually facing on a regular basis. So thank you very much for that. So I've got nobody particularly wanting to ask any particular question on it. So are we comfortable just to note that report? And thank you, Sally, for the comprehensiveness of its detail. Thank you very much. Just looking at the time now, I'm going to go to the agenda, regulatory and statutory reporting item, responsible officer report, followed by the Guardian of Safe Working, where Jerry Lynch is actually joining us. So can I come to you, please, Joe, for the responsible officer report, please?
Yeah, thank you, Martin. So the responsible officer report, I think I'd take it as read, nothing particularly to highlight from it. I'm happy to take any questions.
Right, thank you very much. Any questions to Jo on her report? It's one of the regular ones we have and that we must receive at the board, which is obviously consistent. So thank you for the report. No questions, so we'll note that at this stage. Do we actually have Jerry with us, Dawn?
He's just joined the room, Chair.
Has he? That's great. Thank you very much. Just wait for Jerry to join us to deal with the Guardian of Safe Working report. This is where we actually have our Guardian of Safe Working, Dr. Jerry Lynch, join us, and we've obviously met him on a number of occasions. So welcome, Jerry.
Hi, can you see and hear me, Martin?
No, we can only hear you. We can't see you, but we can hear you okay. Is there anything, Joe, you would like to add before we hear from Jerry?
Yeah, nothing for me. I'd just like Jerry.
Okay, well, anything particular that you want to highlight for the board, please?
So sorry about the video, everybody. I can't seem to get it working. So this is the quarterly report covering up to the 8th of October. The contract specifies a quarterly report from the Guardian of Safe Working. The summary is that the number of exception reports is a bit up this quarter, broadly similar to the same time period last year. Intensity consistently high in medicine. Sometimes is occasionally flagged as unsafe, usually by the most junior of the trainees. We've had some new rotas for the FY1s from August, which have not resulted in any breaches of maximum hours. The ask is for noting. In the detail, 136 exception reports, some related to education, service support. Total overtime hours 163, 3 labelled as immediate threats to safety, 2 from the AMU. All these we try and get feedback, and if it looks like there is something genuinely concerning, get in touch on the day with the divisional teams to see what can be done to sort it out. No fines. The breakdown is, as you see, the qualitative examples. I always put in one that is the most concerning and representative sample of the others. So we had an issue with both induction and being below minimum staffing is the one I've singled out there. What are we doing about it? On AMU, where the pressure is often the greatest, thanks to work from the workforce team, more often than not now there is a minimum of 5 trainees, and that does help with reducing exception reports. Dr. Roycroft has led on a lot of rota revision. There are always ads out for consultants and clinical fellows. and sometimes it boils down to workforce having to play this on a day-to-day basis and move trainees to where the need is greatest. We have a junior doctor forum where lots of other issues are highlighted. We try and work through those and resolve them. And that's it from me.
Thank you very much for the report, Jerry, as you always. I've got Sally and then Rumit, please.
Thank you, and thanks, Jerry. One thing I do when I see this report each time it comes is try and triangulate with the work that we do operationally and what we see escalated through our daily meetings through the operational teams. And it does feel like this often reflects that. So it's always a useful touch point for me, particularly with yourself, if there's more that we can do in terms of operationally to support with that, noting, and again, it comes through the updates that we get, the work that Dr. Roycroft's done with the teams around the rotas. And so we've started to, it's felt like we've started to see the benefits of that. So it was really just to check in if there's more that you need from an operational perspective that we can support with.
Thank you very much for that, Sally. No, I do think I've had a look, because the next quarter is also, we're also through the next quarter, and the numbers are down even for that winter one, which is pleasing, and suggests that the support that you're providing is making a difference.
That's good to hear. Thank you. Finally, Rumit, please.
Thank you, Chair, and thank you, Jerry, for a very comprehensive report once again. Just a quick question, which is to do with education supervisors have struggled to keep up pace with the volume of exception reports. Yeah. Is there any learning from this, and how do we try and implement it? Because obviously this is quite important when you're a junior doctor just having qualified, that you get that extra support, and also not having an induction is not a good start, is it? So just want to get your assurance that we're doing something about it.
Yes, we did send out reminder emails probably in August now, and that has, I do get, I think when I say they've struggled to deal with them, I think the contract specifies a week. It is very hard to arrange for an educational supervisor necessarily to, or a clinical supervisor necessarily to meet in that time frame. So I'm not meaning to suggest that the support is completely not there, simply that it sometimes doesn't happen within the specified time frame that it should. So I don't get the impression that the trainees are unsupported, and probably I should maybe be a bit clearer. What I'm saying is that, if you've worked an extra hour, it's supposed to be dealt with within a week, and so I tend to try and go into them probably on a monthly basis and mop up any that have been left off. So there is, obviously, there's training for educational supervisors that goes on all the time, and I have not had a trainee come to me and say, I am completely unsupported by my supervisor. So it's more of the technical dealing with it.
Okay, thank you.
Thank you. Just in finishing on this particular item, then, obviously it's down for us to note. If I could just mention to yourself, Joe, as our new medical director, our previous medical director, as part of this report, emphasised that he regularly met with junior doctors in support of Jerry, and I think actually that was good assurance to the board that we got a good relationship and good engagement. So you might just give some thought to how, obviously in the use of your time, how that particular item can be obviously maintained in some appropriate way. So thank you.
Yeah, noted, Martin. I did actually attend the Junior Doctor Forum yesterday, so had the opportunity to meet with several trainees. So yeah, I will feed that in.
That's great. Thank you very much indeed. Jerry, thank you very much again, and thank you very much for undertaking the role that you do.
Thank you.
And the way that you actually present it to the board, it's excellent. Thank you.
Thank you very much indeed.
Thank you. Bye for now.
Bye.
We'll stick with the regulatory and statutory items. There's only one more left here, so we'll pick up mortality and learning from deaths report. And again, looking to you, Joe, anything that you'd like to highlight to the board for us, please?
Yeah, just to flag really report as noted, but that our shimmy continues to decrease, which is reassuring, and to highlight on the 360 assurance report that was completed, 13 of the 15 actions are now done, and really the remainder and the main focus for this quarter is going to be embedding a more qualitative approach to the SJR reviews. So the advert is currently out. The advert went out at the beginning of this week, so we'll hopefully have some consultants recruited to those posts to develop that work. But I don't know if John's here. So any questions, happy to take.
Okay, thank you. What is really good here, obviously we as a board obviously focused on mortality and this whole area, and it's been quite a success really in terms of the improvements that's been made. And I think the challenge now is obviously sustaining that position that we've got ourselves to. So this report obviously is going in the right direction. So thank you for that, Joe.
Yeah, I think there's been enormous progress by the team. I was really impressed when I met with John at the work that's gone on in the last year. So to me, it's just embedding that learning in the future.
Thanks very much. So we'll note the progress being made there. Thank you. Could we now, I'm sorry to move about on the agenda, but we'll now go back to P1923, which is the operational plan report. Again, another comprehensive report. And Michael, anything specifically that you'd like to highlight, please?
Just purely that this relates to progress for months 7 and 8, and it indicates that 10 of the 13 objectives are green and on track for delivery. The positions have been through the relevant assurance committees, with the exception of People Committee, which was a development session in December. So they will be due to go through the next People Committee. And again, Chair, I will take any questions on this document.
Yeah, okay, thank you. It's disappointing, unfortunately. I know it's obviously got to timing, but the People Committee haven't really looked at these for 2 cycles now, really. So obviously we'll be pleased to hear the committee at after the next meeting, please, on this. Any questions or comments? Or are we comfortable to note the report and hopefully progress continues? So we'll note the report, and obviously we'll receive some feedback from the People Committee when it has a chance to review the oversight that it has. Thank you very much. Let's now move on to the finance report, please, and to our Finance Director, Steve Hackett. Steve.
Thank you, Chair. So just to present the November position for the Trust and the forecast for the year end. So just to confirm, the Finance and Performance Committee have received all the information that's presented to board today, and did give positive assurance in terms of the position as at the end of November and forecast for year end. So in terms of income and expenditure, in the month of November we slightly overspent by £276,000 over and above forecast, but the year-to-date position was still in surplus at £120,000 better than plan. We were forecasting with divisional support just under a £1.5 million adverse variance as at the end of excuse me, March 23, but we do know that we have reserves in place that will cover that. So still reporting externally to the Integrated Care Board and NHS England that we will be able to meet our financial obligations by year end and meet the £2.7 million deficit plan. In terms of capital expenditure, again slightly under in terms of the November position and under in terms of year to date, but we had a really helpful capital monitoring group where colleagues took on actions to make sure that we are going to fully commit our £13 million capital allocation by the year end. There are some unders and overs in terms of specific schemes, but we are confident that we'll be able to utilise the whole of the £13 million allocation. In terms of cash position, still strong in terms of the year-to-date position at the end of November. So we were £8 million better than plan in terms of the cash position at the end of November, and forecasting that we'll be slightly better than the year-end forecast by £1.5 million. So the cash position is still strong going into next year. Just to touch on next year's planning, we are forecasting that as all organisations in the NHS will have a challenging process in terms of allocations for next year, and so we're working heavily with the divisional colleagues and corporate areas to try and make sure that we've got our cost improvement plan in as best shape as we can do going into next financial year, which will hopefully give us a good start in terms of cost improvement programme that we need to deliver for next year. And I'll pause there, Chair.
Thank you, Steve. I mean, it's always encouraging to receive a report of this nature, and really just to thank all the management team, really, in terms of the oversight and focus that you've put on, establishing strong financial foundations. I know it's a continuous challenge for you to do so, but it's very encouraging to see the progress that we've made and how you as leading on this area, Steve, are actually controlling and managing the budgets along with the division. So thank you for your efforts there. And I don't have any colleagues who want to add to that. So can I just note that report and thank you and colleagues for the activity and progress we're making. Thank you for that. Let's now move on to the nursing workforce safeguards gap analysis. Again, a very full report here. And again, it's just obviously colleagues will have read through the report, Helen. It's just highlighting any particular points specifically that you want to highlight, please.
Thank you, Chair. I think it's just to emphasise that this is, we've taken a bit of a reset. There is a huge amount of work going on in this arena, and the gap analysis document gave us a chance to benchmark where we're at against a number of national documents that have come out over the last couple of years, and just refocus what we're doing, in particular around some of the licenses that are available to ensure that the things that we do, such as establishment reviews, are being done against evidence-based models, and that we have appropriately trained staff in place to do all of that, which I'm pleased to say we now do, and that will be the process we follow going forwards. A number of pieces of work do show us being partially compliant because they are still works in process, but I think we're in a stronger position to know exactly where we're at. Some areas are progressing incredibly well. We've just been asked by the regional team to present the work we're doing around retention for support workers at an event at the end of this month, as it's been noted that we're an outlier in a positive sense for the work that we're doing there, which is really good to hear. Going forwards, there's going to be twofold reporting of the information coming out of this report. So through the People Committee, we will be reporting on the processes and the nuts and bolts, I suppose, of retention, recruitment, and the processes that are in place to ensure that we have the workforce trained and the numbers that we need. But in terms of the outcomes from that, we'll be reporting through Quality Committee, because this has a real impact on our patient care that we're delivering and the quality elements of that. So there is by two different ways of reporting this. There is a huge amount of information there, but I'm happy to take any questions that anybody has.
Thank you, Helen. Sally, and then Heather, please.
Thank you, and I'll be quick in interest of time, but I think it links quite nicely to something Joe picked up earlier around capacity planning and workforce planning. So one of the things that I've been keen to see, and it's in here, is the workforce tool around for emergency care and emergency department. I think it's something emergency departments often grapple with in terms of how they plan the nursing workforce. So it's great that it's in here and to be implemented from January. I know staff are starting to get trained, so it's an important part of their workforce plan and the workforce planning that we're doing with ED and our UECC. Are they going to be ready to go then, and that'll be rolled out in Q4 to support us planning for next year?
Yeah, so it is going, but what they've said is that we need a year of data before we can reliably use the information that's in there. So we will be using the data from day one, but in terms of that national reporting and the confidence in the data that's been produced, it will need a full 12 months worth of data. But it's a really key point that up until now, for many years, we've reported around using evidence-based tools for inpatient areas, but we've now got the licenses to do that across the board for areas such as ED, community, which are areas that have previously been excluded. So it's really positive.
Thank you for that, Sally. And Helen. So I've got Heather and Rumit, please now.
Thank you, Helen. It's I think it's a really, really useful tool, something I know we've discussed on many occasions. The bit that I was slightly unclear on, and maybe we could pick this up at Quality Committee, is the impact and how it gets reported through here between our establishment for funded and unfunded beds, and that's where we get the stretch within our nursing capacity when we actually have those unfunded beds, and how that gets reported through here, because I think that's a key point in the number of nurses we have available.
Yeah, and we can certainly pick that up within the committees, but the work that's referred to in here around the Power BI tools that we're developing, where we have, it's the next step from the heat maps we have at the moment, where we triangulate across staffing numbers and quality metrics. That will apply to those additional beds that we have open as well. So in all those areas, we will be able to do it. So for example, we've already set that up for Sitwell Winter Ward, even though it only opened this week, so that we're including those in those metrics as well.
Thank you. And finally, Rumit, please.
Yeah, so Chair, I'll keep it very brief. I mean, we have regular debates about care hours per day, established and funded beds versus non-funded. And my fear is that we're not going to get out of this crisis, be it whether it's summer or winter. I think this is all year round pressures. So should we really be looking forward to saying, well, we ought to have a collective between funded and unfunded beds, and actually do our staff planning accordingly, because I can't see ourselves getting out of these crises for the next at least 2 years. And the way the health service is going, I think the pressures are going to be all year round. So we have this winter planning and so forth, but I just wonder whether we ought to look at it a little bit broader than that. Just
yeah, thank you, Rumit. I think that's a good point that you make. Do you want to add to that, Sam?
Yeah, I was just going to add, so the piece of work Helen and I are working on is around, as we come out of winter, what that looks like. And it's a piece of work we're doing to model the bed base and bed capacity. And what Helen would like to do, Helen himself would like to do, is that we introduce escalation capacity that we can use all year round, so we can flex into under times of pressure. And that will also then absolutely help in terms of planning staffing requirements. So it's in train as part as we cut through Q4 as we get into coming out of winter for the surge plan all year round.
Smashing. Thanks very much. As you say, Helen, a comprehensive piece of work, and thank you very much indeed for undertaking it and obviously presenting it in the way you have. I think it's very encouraging as well is that it's not just you looking at this as our chief nurse, and you know how we've got our chief operating officer wholly engaged in it as well is very encouraging in terms of how we move forward. So thank you for that. We're asked to note the report, colleagues, and obviously recognise the work that's gone into that. So thank you very much. We've now got on our agenda the committee chairs logs, and thank you to the committee chairs for those logs. And I'll just very quickly just go through and just ask each chair if there's anything particular they want to highlight, based on the fact that we've got plenty of reports on the agenda here that obviously relate to some of their work. But if I can come to Nicola Bancroft, please, the chair of our Finance and Performance Committee. Anything, Nicola, you'd like to add?
Thanks, Martin. We were going to just flag the operational point on the log, but I think Sally's already covered that comprehensively in her update, so nothing really to add to that. Thank you.
Thanks very much, Nicola. Quality Committee, anything, Rumit, particularly you want to highlight?
So only thing that I would take it as read, the only thing I would like to highlight, and perhaps Helen can probably elaborate a little bit more, is regarding infection prevention control and the cleanliness issues that have been going on within the trust and what's been done about it. So perhaps, Helen, just a very brief statement with regards to that.
I think it's just to acknowledge that we're aware that we've had some problems with this. We've been working very closely across the clinical divisions, infection prevention control team, and the estates and facilities team to put some immediate actions in place. We have undertaken an external review of where we are at against the cleaning standards. We've employed additional agency cleaning workers to bolster numbers, and that means we've certainly seen more people out and about doing cleaning within the organisation. We've also started a new deep clean programme that has been challenged because this has obviously happened at the same time as we've had an unprecedented number of beds open, so we've had limited capacity to decant patients in order to deep clean the bed areas, but we've been taking opportunities as and when we can to do that, but there's a bit of slippage on that, but we still persevere with that. I think it's fair to say we are not where we want to be at the moment. We've still got a significant piece of work to do, but I think we're fully sighted on what the problems are, and we'll continue working on that. And we are monitoring this through our executive team on a weekly basis, and we'll keep feeding into Quality Committee as well.
Thank you. Thank you for highlighting that, Rumit, and thank you for the report. It is something that Richard's spoken to me about, so I think we will be getting sort of a report on a future agenda, really, because it's a very key area of the actual operation of the trust, and therefore we need to be mindful of it. So thank you for highlighting it, Rumit. Thank you. People Committee, please. Anything, Joe, you want to particularly mention to the board?
Yeah, as you said, we've covered much of the material we've had at recent People Committee meetings. The one thing I would mention is that on the BAF assurance framework, the People Committee is now going to see updates against the risk D5, which, although it's a delivery risk and it goes to Performance Committee, it relates to the the resources, financial and human resources in the trust and the ability to meet performance targets. So we felt it would be helpful for people to see that because of the human resources elements.
Thank you for highlighting that, Joe, and that's a good example in terms of making sure we've got appropriate oversight from different committees to ensure that the outcomes are what it is that we want. So thank you very much for that. So we'll note the chair's logs. We'll come to the board assurance framework, which is at P24 23 there, and this particular report, the elements of it have been through our assurance committees, and obviously we just asked as a board to actually just provide that oversight. Anything, Michael, you want to particularly highlight for us?
Yeah, thank you, Chair. So in relation to U4, which is around capacity and leadership, that risk has changed. It's gone from an 8 to a 12, and that's based on a change of likelihood around the recovery position. And the other point to note, OP3, which is around service configuration, that remains a 12, but there's a strong potential that will change and improve in Q4. Outside of those two, there are no changes to report in terms of scores, chairs, and again, happy to take any questions on the document.
No, thank you very much for that, Michael. I get a feel is that the actual board assurance framework is now starting to work more effectively, particularly through the assurance committees. So in terms of the work that's been done by the assurance committees, as a board, are we happy to approve those minor changes that have been identified? All agreed? Thank you to everyone in terms of progressing this whole programme, and obviously in Angela Wenziki's absence, obviously thanks for her leadership in terms of making some of the improvements we've got. So that's good. Thank you. Right, colleagues, a couple of safeguarding related papers. The first one, P2523, NHS England Safeguarding Review. And again, Helen, usually, what it is that you particularly want to highlight for us.
Yeah, I was just mindful of the fact that it was last October when we had the NHS England team in to review our safeguarding processes, and I've not been able to present you with a written report back from them because I haven't received their formal feedback yet, but it has been promised to me before the end of January. And it's really just to highlight the fact that they are seeing this more of a quality improvement process, and they will be working with us closely throughout 2023. So we do expect we will have regular updates coming through from the team about the progress against the areas that have been highlighted, which are predominantly linked to the adult safeguarding programme. And that will report throughout the forthcoming year through Safeguarding Committee and the Quality Committee. I'm happy to take any questions.
Could I just ask, please, Helen, is there anything we should be concerned about as a board at this stage? Because we've been doing significant work on safeguarding for quite a long time now. Is there anything particular that you would express your concern about?
No, it's a short answer. I think we've made some really good progress with paediatric safeguarding, with maternity safeguarding, and a huge amount of progress with our staff mandatory training around this, which I think is evident to see, and some of the culture and changes in the approaches we have. We do recognise that there's changes happening this year with liberty protection standards, which is going to bring a significant additional piece of work in. There are some changes in our safeguarding team. Our head of safeguarding is taking flexible retirement this year, but she is coming back to lead 2 days a week on liberty protection standards. So that will give us some continuity there and that extra resource there, which will help. We're currently out to advert for a new head of safeguarding, so there will be, some, that will be a really, hopefully a really positive appointment there. So yes, there is the recommendation of that work needed around LPS and some work needed within the adult team, but I think that we have plans in place to develop that.
Yeah, right, thank you. So last point on this one, please, before I move on, Zleka.
Yeah, it was just a quick one. Helen, I noticed when I was reading through the paper that domestic violence was mentioned, but I think there was only the one mention. And I know we've had a conversation outside of this meeting, and I suppose for me, I'd like to be able to see, in terms of adult safeguarding, a bit more maybe reference to those sorts of issues.
Apologies, Lacra, I didn't hear, in relation to
domestic violence. Domestic violence. So obviously that's something that we've had the conversation that we'll talk more about outside of this meeting as well.
Yeah, and that is a key area for the safeguarding team. And in fact, when we get onto the next paper, you'll see that there is reference to that within the annual report as well.
Okay, well, thank you for that point, Zleka. And this is constantly improving all the time. And as we say, quite a lot of dynamic issues, obviously, in the health service that we need to be consciously aware of the changes on. So thank you for highlighting that particular point. And obviously we'll receive the actual final report or the detail of it in due course then, Helen, won't we? So
that's correct.
Thank you. So we'll note this particular report and the initial outcomes of that review. Let's now move on to the Safeguarding and Vulnerabilities Team annual report. And again, actually just referencing, the role of the board and the role of the assurance committees. This particular item has been to the Safeguarding Committee and it's been to the Quality Committee. So it's coming in here for us now at this particular point. So again, anything particularly, Helen, that you want to raise?
No, I don't think so really. It is the 21 to 22 report, so we just need to bear that in mind when we're looking at things like training figures. This is sort of like the historical year-end position. It's just taken a while to come through with all the data. And it's really just if there's any questions, and if not, if the board are happy to approve it, this will then get published on our trust website. So this is our public-facing document.
Smashing, thank you. A lot of work's already gone into this, colleagues. It's now presented for us for sign off. Are you all agreeable? All approved? Thank you very much indeed for that. We'll now move to the item on the agenda on terms of reference, please. P3023. Again, Michael, as I said earlier, we're working you very hard today. Obviously, these terms of references have been through the assurance committees. I suppose I'll ask is, are there any questions or comments from colleagues on any of these terms of reference? Okay. Anything to add, Michael? Or are you happy that the board actually?
Happy to proceed on that basis. Thank you.
Smashing. Thank you. Well, thank you, colleagues. So we'll approve terms of reference. Thank you. Our next item on the agenda is escalations from the Council of Governors. And as I mentioned earlier on the agenda is we don't get too many escalations from the Council of Governors. And therefore, when we do, clearly it is an important issue for us. So I know our executive colleagues have undertaken some work to really review what the concerns were for the Council of Governors. And Michael, over to you, please, if you could just take us through the executive's response or the organisation's response.
Yes, certainly. So in terms of the Council of Governors that met fairly recently, there were 3 specific escalations, and that was around staff survey. Specific concerns came in terms of the actions that we've taken since the last survey, based on the position, the results, which was bang on the median for the country. So we're absolutely average, and that's not the place we wanted to be. but there had been a journey leading to get to that average position from a lower quartile. So there's a positive story to be told, and we'll see more of that story, I guess, when the results are embargoed from the more recent areas. Also, staff sickness came up with the high levels, which has partly been impacted by COVID, but there was an interest in what we've been doing in that space. And finally, health and well-being, at least one of the governors had a walk around and met with some colleagues, and facilities was as a specific issue that came up as a result of that. We've pulled just a few slides together, which are in the pack. Steve's just going to talk through the first two areas, staff survey and sickness, and I'll touch on health and well-being, if that's okay. Can I just first, before we do that, can I just do a time check, Chair? Are we okay to spend 3 minutes on it or so?
Yes, of course. Yeah, no, we've got to deal with the agenda in front of us, so we're not going to fall off a cliff at 11:30. It's just actually making sure that we keep to reasonable time. But let's deal with the business appropriately, Michael. Thank you.
Thank you. I'll hand over to Steve then. Thanks, Steve.
Thanks, Michael. Thanks, Chair. First area, I think, where an escalation of was risen from the Council of Governors around, I think it was about the response to the staff survey. So we do the staff survey every year, and I think the feedback was we don't necessarily see what happens as a result of it. So what we've tried to do in this presentation is, first of all, I think in terms of a strategic context, I think for newer members of the board, I think when Richard Jenkins first joined us as interim chief executive in 2020, one of his key areas of priority was staff engagement, particularly as measured through the staff survey. So I think it was helpful on the first slide to show how we've significantly improved our response rate to the staff survey over a period of years dating back to 2018. So we've moved from 38.5% response rate in 2018 up to 61%, which we reported earlier. And I think that's a significant improvement in the response rate. It's important that we get the views of staff so that we can do something about it. And I think what we set out later in the report, under the themes of the people promise, is the actions that we've taken since the last survey to address some of the areas of concern that have come out of the staff survey. I think I'll probably also add, in terms of assurance and governance, this is an item that is scrutinised through the Assurance Committee, the People Committee, on a regular basis. So we do have an assurance route to get assurance through that, which is then reported back to the board through the chair's log. And I think we also benefit at the People Committee that we have a regular observer from the Council of Governors at the People Committee to sort of take stock of that assurance on behalf of the governors. Just a few highlights I'll pick out from the actions since the last staff survey. And one of the things I've not put on here, which in terms of triangulating with the rest of the agenda, is that our approach to reciprocal mentoring and equality, diversity and inclusion. So we've done a significant amount of work in that area, as you've heard at the last board and this board, around doing that. And whilst the results are embargoed until February, I think we will see some positive responses around movements around equality, diversity and inclusion since the last survey, which hopefully will give some assurance to governors that we are listening. It's great that more people are telling us what their experience is, but we are listening and acting on it. We've also done some work around compassionate leadership. We've done some work around the behavioural framework, which has been adopted by the divisions and amended for their particular areas, because each division gets their own staff survey response, so they can tailor what they need to do to their certain organisational specific areas within the division. So I'd probably call out the surgical leadership team on that, because I know they've taken the staff survey extremely seriously. It reflects this year in that they're the highest response rate from a divisional perspective. And whilst they're not where they need to be, they recognise that they've shifted significantly in the last 2 years with the focus, energy and effort that the leadership team has put into there. So I'll not go through each one because I'm mindful of time, but hopefully the report can also, presentation can also be circulated to the Council of Governors to kind of reassure them around some of that assurance that we've done. In terms of sickness absence, again, we're doing a deep dive in January's People Committee next week around assurance about attendance and the management of sickness absence, particularly the split between short-term and long-term sickness absence. I was reflecting when putting this together that we introduced a new managing attendance policy in June 2020, which was 2 or 3 months into a global pandemic, which probably isn't the best time to measure the impact of a new policy. You'll have seen, again, looking at other items on the agenda around the focus from a national operational planning priorities, attendance management is going to be one of the priorities for us going forward this year. And again, we'll discuss that more at People Committee next week. We also provide significant amount of training for managers around managing attendance. And we also track long-term sickness absence. Again, recognising that sickness absence isn't where we would want it to be, but we've got a range of actions in place, including support for employees around employee assistance programmes, the full range of our health and wellbeing offer, including financial health and wellbeing as well. I'll probably pause there and pass over to Mike in terms of some of the other facilities type health and wellbeing initiatives that we've introduced.
Yeah, thank you, Steve. And just adding what you said about the surgical triumvirate colleagues, in the last 12 months running up to the more recent staff survey, they held 13 listening events, 30 rather, with 30 departments within surgery. So that's tremendous, really. It's that level of engagement there is really adding a lot of value. What we were told, actually, by our colleagues, there are 3 things that if we could improve would make a big difference on health and wellbeing. And that's particularly, firstly, it's coming from nursing, and it's around ward moves. So staff really, you can understand, don't like to be moved at short notice. The second point was around changing room and locker facilities for colleagues, that we need to improve those. And finally, hot food out of hours, which is in addition to the current vending options which we have, and which is the standard across those and other trusts in the area. So firstly, with regard to staff moves, obviously recruit to all vacancies is essential, really. But nursing colleagues led by Helen, with work that Cindy's doing, are really looking at retention of nursing, which is a piece of work that starts in February this year. They'll be developing health and wellbeing checks and making contact with staff who are moved just to say thank you. And also trying to look at the feasibility to try and limit the number of moves to different wards that staff can be moved to. Ultimately, unfortunately, we do have to have moves in place just to manage our capacity and short-term sickness, but the moves will be kept to a minimum. In terms of facilities, so we're absolutely mindful that we need to spend a significant amount of our capital monies on refurbished kitchens and restrooms and locker facilities. In 21-22, 555k was spent just on those areas. This year, we agreed an additional 55k, which you may have seen in the objective update for health and wellbeing, and have committed 300k in total for this year, again, which is around staff room upgrades, shower facilities and changing facilities. So that's an ongoing project. And finally, hot food. This is particularly hot food on the night where we know the challenges are. We currently have a vending option, as I mentioned, which is the standard across other trusts. But our catering partner, ISS, have committed to commence a trial, commencing the first week in February, where we will have an out-of-hours hot food counter service from our servery, which will run between 10 p.m. and 2 a.m. So collectively, I think these things will make a difference to our colleagues' feel, but ultimately our staff survey, once the embargo is released, will give us a good indication if what we've done has actually made a big difference. And again, Chair, I will pause, and Steve and I hope to take questions on the presentation.
Thanks very much, Michael and Steve. We're not going to take questions on this. This is an item that's been escalated from the governors. So as the chair of the Council of Governors as well, it's very important that obviously we present this back to the next Council of Governors meeting in February. Just a couple of points I'd make, please, as the chairman of the Council of Governors is, it really is encouraging to see all the things that we've done with regard to the response of the staff survey, and particularly in the surgery division. As you know, we've got a number of staff governors, and sometimes actually the story that we hear at the Council of Governors is not always the same as the information about what it is that's actually happening. So I think communication is actually vital in this area. Although we're doing like 13 listening events, we've got to make sure that that is widely known. And the fact is that it's actually flooded in a sense, so that we are in responding to their concerns. That is the case. Now, I've actually been on 3 nurse walkabouts over the last 3 months, and clearly the whole issue about staff welfare, and particularly sort of staff rooms, changing rooms, etc., have actually come up on each occasion. And we were at one yesterday, and I understand that there's a new facility being developed on A floor, on about new shower area and changing rooms. And I just want to emphasise it's absolutely crucial that we get that done as soon as possible. I did speak to Richard yesterday, and he gave me the indication he thought that that was going to be completed in this financial year. So can I just get assurance that that is the case? Because that's obviously going to be a major impact in terms of changing and shower facilities.
Thank you, Chair. Could I bring Ian in, please, as our Director for Estates?
Yes, please. Thank you.
Yes, hello, thank you. So we're looking at commencing the new shower facilities imminently, and they're planned to be concluded by at the end of March.
Okay, thank you. That's all I needed. So that's in the minutes, thank you. And we will be seeking assurance that that's done, because this is actually back into our operational objectives as well, given oversight by the People Committee. That's one of those key items. So we've got to make sure that's all triangulated. So thank you very much indeed for responding to that escalation from the Council of Governors. That's really helpful. Thank you. Coming back to our agenda, we've got review of the annual board planner. So we'll note the forward work programme that we've got there. In terms of any other business today, we actually have received a couple of questions from one member of the public. So we'll actually take that question, and we'll actually take the question and put that in the minutes, and our chief nurse, Helen Dobson, is going to respond. So perhaps if I could just ask you, Dawn, please, if you could just read out the questions, please, that we'll incorporate in the minutes.
Certainly, Chair. The questions relate to a visit by one of our members of the public to our wards. The first question is, when deciding to convert a bed space into a workstation, was consideration given to the number of bed spaces that would be lost? This would have been carried out at a significant cost to the hospital. Was this an end of the year decision to spend the money, the capital money? Has a review of the cost against patient care been carried out to see if this had been value well spent? Has this been done on more wards and as such reduced bed numbers?
Thanks very much, Dawn. Helen has been made aware of this. We actually got the question in yesterday, so it's been to Richard and Helen and Michael and others. So Helen, if you could just give us a response, please, to those points.
Yeah, absolutely. And we can put a more full response onto our website, because it was only yesterday. So certainly I haven't got some of the financial information at this stage around this. But just to put it into context of what this is about looking at our AMU footprint, where we have 5-bedded bays with the 6th bed space converted into a workstation rather than having a 6-bedded bay. I think the short answer is the questions imply that we've done this for reasons of spending capital money, and I'd just like to provide assurance that's absolutely not what this is about. This is about quality of care, infection control and dignity of patients, and just reducing overcrowding, really. So when it's not a recent thing that's been changed within our acute medical unit. When the acute medical unit was designed, it was designed to have 5-bedded bays with space for a workstation, so that we could have staff being closer to patients to provide care. The footprint was in effect expanded, so that it's not about having less beds but having the beds more spaced out, which is absolutely the right principle that we should have when we're doing estates planning, and something I'd hope to see us doing more of as we go forwards. So we have that model of having a workstation within the bay on AMU and within the short stay unit. We also have 5-bedded bays within Ward A2, which is the other area that does it, although it's slightly different there. In those areas, it's to accommodate a bathroom within the bay, which again, I think for patient experience is a better model than having 6 patients within a bay. And it is something we would look to do more of as we go forwards with our estates planning. For me, an issue to pick up is around whether or not we are using those workstations effectively. But I think when we have sufficient staff on a ward, keeping a nurse or a doctor within the bay with patients is the best use of that space, rather than congregating in a central area. So it wasn't done to use up capital money. It was a planned thing for patient experience. And it doesn't impact on total number of beds that we have across the organisation, but we can give a more specific response as to what the costs involved with that are within on our website.
Smashing. Thanks very much indeed, Helen. So if we can make sure that the question and the response goes on our website, that'd be really helpful. Thank you. So in terms of finishing our agenda, I'd just like for recording of the minutes, please. Martin Temple has sent his apologies, and he sent his apologies in over a week ago. So unfortunately, I've just missed that in terms of presenting it at the beginning of the meeting. So let's record that. And finally, I'd just like to mention and record in our minutes that unfortunately, this is going to be the last meeting of one of our non-executive directors, Nicola Bancroft, who unfortunately, due to personal changes, has had to offer her resignation and will finish as a non-executive director at the end of January. So just want to record in the minutes, Nicola, our appreciation for a significant contribution that you've made, and you certainly will be an individual who will be greatly missed. We do understand why, and thank you very much indeed for what it is that you've done. We really do appreciate it. So thank you. That comes to the end of our agenda. I'm sorry we've overrun slightly, so we'll close down the public part of our meeting. We do have a confidential part of our agenda, and we'll start that in half an hour's time. So we'll start that at 12:15, if that's okay, and look forward to seeing you all then. Thank you all for your reports and indeed for your contributions this morning. Thank you. Bye for now.